high-yield principles in pathology. Uh, Cellular injury, cellular adaptations, reversible changes that can be physiologic. Hold on. Okay. Reversible adaptations, reversible changes that can be physiologic. For example, uterine enlargement during pregnancy, or pathologic. For example, myocardial hypertrophy, secondary to systemic hypertension. If stress is excessive or persistent, adaptations can progress to cell injury. For example, significant left ventricular hypertrophy will lead to myocardial injury, which causes heart failure. Hypertrophy. What is hypertrophy? It's increase in structural proteins and organelles. Uh, this is increase in size of cells. For example, cardiac hypertrophy. Hyperplasia. It's controlled proliferation of stem cells and differentiated cells, uh, which is increase in number of cells. Uh, for example, benign prostatic hyperplasia. So BPH is hyperplasia, which is increase in number of cells. Uh, the way I remember trophy is the bigger the trophy, the better it looks. So size of the cell is hypertrophy. That's how I remember the trophy is size, and then plasia is the number in cells. Excessive stimulation uh, will lead to pathologic hyperplasia. For example, endometrial hyperplasia, which may progress to dysplasia and cancer. Atrophy is decrease in tissue mass due to decrease in size. Uh, this is increased cytoskeleton degradation via ubiquitin, proteasome pathway, and autophagy, phagy, or autophagy. A decrease in protein synthesis and or number of cells is apoptosis. Uh, Cause include disuse, degeneration, loss of blood supply, loss of hormonal stimulation, and poor nutrition. Okay. Metaplasia, reprogramming of stem cells. Uh, this causes replacement of one cell type by another that can adapt to a new stress, usually due to exposure to an irritant such as gastric acid, uh, which is also known as Barrett's esophagus. This whole thing, or tobacco smoke, which causes respiratory ciliated columnar epithelium to be replaced by stratified squamous epithelium. Um, may progress to dysplasia, which can cause malignant transformation with persistent insult. For example, Barrett esophagus can cause esophageal adenocarcinoma. This is important. They'll give you a history of Barrett's, and then they'll say that there's a malignancy. What kind of malignancy can it be? Then they'll give like squamous cell, small cell, uh, keratin, and all that stuff. But you gotta remember, this is the most common one: Barrett esophagus with esophageal adenocarcinoma. Metaplasia of connective tissue can also occur, right? So, for example, myositis ossificans, the formation of bone within muscle after trauma. Okay. Dysplasia, disordered, precancerous epithelial cell growth, not considered a true adaptive response, characterized by loss of uniformity of cell size and shape, pleomorphism, for example, that is loss of tissue orientation. Uh, wait, Characterized by loss of uniformity of cell size and shape. This is called pleomorphism. Also, it is characterized by loss of tissue orientation and nuclear changes. For example, increase in nuclear and cytoplasmic ratio and clumped chromatin. Right. Mild and moderate dysplasia, that is, do not involve that is, do not involve entire thickness of epithelium, may regress with all alleviation of inciting cause. Severe dysplasia often becomes irreversible and progresses to carcinoma in situ, uh, usually preceded by persistent metaplasia or pathologic hyperplasia. Right. So all of this is just the basic terms that you should know. Again, hypertrophy and hyperplasia, just so you don't mix it up. Trophy is bigger, the better in size. So that leaves plasia for the number of cells. And this one is known for BPH, and this one is known for cardiac hypertrophy. Atrophy is just decrease in size, like shrinkage. Uh, Basically, anything that's not being used in your body will get atrophied. Like spleen can get atrophied, your muscles can get atrophied in paralysis. Uh, Metaplasia is this Barrett's esophagus. It changes or into another cell type. So initially it's columnar, but then it becomes sorry, ciliated columnar, and then it becomes stratified squamous epithelium, and it will have goblet cells because goblet cells are found in stomach, and goblet cells, why? Because goblet cells makes mucus, and the mucus then acts as a protectant from the acid reflux, because acid reflux is, you get that a lot when you smoke, right? Or just GERD, uh, for other reasons. So that can also cause Barrett's. Okay, dysplasia and insult, we did that. Know that Barrett esophagus is known to cause uh, esophageal adenocarcinoma. And then we have dysplasia. Dysplasia is just uh, change way beyond metaplasia. So at this point, you can't even recognize what kind of cell it is. And this will go on to becoming malignant or something like that. Right. Okay, so you have normal cells, it's reversible. Hyperplasia, hypertrophy, atrophy. You see how it's shrunken. Hyperplasia is just more cells than four cells. Uh, trophy, trophy is always bigger in size, the better. So normal cells, it's bigger than that. Atrophy, inability to adapt, irreversible injury, necrosis or apoptosis. Severe stress of injury will cause this. Um, then reversible change in cell structure. So dysplasia, you can't even recognize it, and metaplasia like this. But this, if it continues without you taking care of it, if it continues to be like this, eventually it's gonna become irreversible if chronic irritant persists, right? So then it turns into neoplasm. And then normal cells change in cell type and structure, generally irreversible neoplasia. Okay, cell injury, reversible cell injury, and we have irreversible cell injury. Just means up to a certain point, if you take care of it, it does go back to being the way it was. But after a certain point, it just, you can't go back to how it was in the starting. So, what is considered reversible cell injury? Decrease in ATP, decrease in activity of calcium and sodium potassium pumps. Uh, this will cause cellular swelling, because if Na doesn't go out, the water doesn't go out, so then the water will cause the cellular swelling. Cytosol, mitochondria, endoplasmic reticulum, Golgi, right, which is the earliest morphologic manifestation. So over here you have a normal cell, so reversible injury, and this is just cellular swelling. So all this stuff is going to swell up, the cytosol, mitochondria, endoplasmic reticulum, and Golgi. That's the distribution center, right? So this one makes the proteins and all the other sterols and all that stuff. Okay, this is the membrane blebbing, and this is nuclear chromatin clumping, right? So ribosomal, polysomal detachment, so decrease in protein synthesis, will happen. Plasma membrane changes, the blebbing, nuclear changes, for example, chromatin clumping, right? Uh, so you have chromatin clumping. Rapid loss of functions, for example, myocardial cells are non-contractile after 1 to 2 minutes of ischemia, right? Myelin figures, so aggregation of peroxide, peroxidase, or peroxide peroxidized lipids. Okay. So yeah, just know as long as it's these things, it is considered reversible. Um, so when does it become irreversible? Just thinking about it, if there's like perforation in the membrane, I guess, right? Uh, as long as they're just clumped together and rather than just breaking apart, the chromatins, right? So here we have nuclear degradation, we have plasma membrane damage, right? So those two make sense anyways. But then there's also rupture of lysosome and autolysis. If you have rupture of lysosome, it's going to leak out all its uh, proteases and all that stuff. That's going to also destroy everything inside the cell. Kind of like how your stomach is. So your stomach has hydrochloric acid. So if your stomach gets perforated or something, the hydrochloric acid is going to damage everything else, right? Increase in mitochondrial permeability. So this thing functions based on this closed system of protons and electrons. So now if you have other things coming, that whole chain, the electron transport chain, is going to get disturbed, right? So that as well. So irreversible cell injury, breakdown of plasma membrane will cause cytosolic enzymes, for example, troponin, leak outside of cell, influx of calcium, which leads to activation of degradative enzymes. Mitochondrial damage, dysfunction, for example, loss of electron transport chain, so decrease in ATP, right? So that's the whole thing about mitochondria. That's why it's considered the powerhouse of the cell, from all the memes. And rupture of lysosomes uh, will cause autolysis. Then you have nuclear degradation, also known as pycnosis. Know these terms. Uh, so pycnosis is nuclear condensation. Okay. Then you have karyexis. That's nuclear fragmentation caused by endonuclease mediated cleavage. And then you have karyolysis, which is nuclear dissolution. Okay. So pycnosis is condensation, nuclear condensation. Karyexis is nuclear fragmentation. You can think of like hex as like you can hex something, it's gonna make fragments of it, right? So you can think of that like that. Karyolysis, nuclear dissolution. I don't know how to remember that, but lysis is anyways something that's like really powdered up, I guess, and then you use a powder to make a solution. So that's the dissolution, and then that just leaves pycnosis for condensation, because you pick a trip to go to a place where there's, you know, maybe like a hill station or something, and then there's condensation there. I'm just spending time to remember these. You remember how you want, but this is important to know because these terms will show up in the questions. and they do make differentiations between the three terms. Um, Amorphous densities inclusions in mitochondria, right? So amorphous without a clearly defined shape. So it's just gonna everything's gonna be again clumped up or something in the mitochondria, so you can't make out what is what. So yeah, rupture of lysosomes and autolysis, plasma membrane damage, mitochondrial permeability, and then nuclear degradation. All of this can then go into cell death, and where everything is just destroyed. This is the end game of everything. So necrosis. Okay. Now apoptosis. Okay. This is a very important concept you need to know. Uh, but in an overview, you already know what it is. Apoptosis is just cell death, right? So here you will have the Cas spaces. We'll talk about that. We'll talk about the uh, be clever and live or bad genes, or and then by bad I mean this one. And be clever and live is just BCL. Bad is BAX. And yeah, so the Cas spaces, we'll talk about that and all that. Okay. So ATP dependent programmed cell death is called apoptosis. Intrinsic and extrinsic pathways, both pathways activate caspases. Okay, that's important to know. Cytosolic proteases. So this is what caspases is. It's just cytosolic proteases. And what do proteases do? They just, cleave everything. So what happens when this is activated? Cellular breakdown, including cell shrinkage, chromatin condensation, and membrane blipping, and formation of apoptotic bodies, which are then phagocytized. Characterized by deeply eosinophilic cytoplasm and basophilic nucleus, pycnosis, and karyexis, cell membrane typically remains intact without significant inflammation, unlike necrosis. DNA lettering fragments in multiples of 180 BP is a sensitive indicator of apoptosis. So, yeah. Main thing to know is that caspases are cytosolic proteases. Apoptosis is all about ATP dependent programmed cell death. And then what it does. Right? So there are two pathways caspases get involved or get activated. One is intrinsic pathway, that's the mitochondrial pathway, and the extrinsic pathway or death receptor pathway, that's with the PDL ligand, I guess. Or is that somewhere else? We'll see. Okay. So intrinsic pathway, it's involved in tissue remodeling in embryogenesis, occurs when a regulating factor is withdrawn from a proliferating cell population. Okay, so involved in tissue remodeling in embryogenesis occurs when a regulating factor is withdrawn from a proliferating cell population. Okay, so regulating factor is like these things right here. Okay, from a proliferating cell population, that's just saying that like when cells are developing. So for example, a decrease in interleukin 2, that's T cell stimulator, after a completed immunologic reaction will lead to apoptosis of proliferating effector cells. Also occurs after exposure to injurious stimuli, for example, radiation, toxins, and hypoxia. Right. Regulated by BCL2 family of proteins, BAX and BAC are proapoptotic. Okay. So that's the backs and back, and this is the BCL. So they're both pro-apoptosis. That just means they both activate apoptosis. So they're both acting on apoptosis or caspases or whatever. So BAX and BAK are pro-apoptotic, right? So it's bad for survival. So this will cause activation of caspases, and this will cause inhibition of caspases, right? So while BCL2 and BCLXL are anti-apoptotic, so you can think about be clever and live for yourself, because this uh, inhibits the apoptosis. So when you when a cell can't die, they're gonna live, right? So it's telling them to be clever and live. Backs and back form pores in the mitochondrial membrane. Release of okay, so yeah. So this is how it causes activation of caspases or apoptosis. Uh, backs and back, when they activate or act on mitochondria, what happens is leakage of release of cytochrome C from the inner mitochondrial membrane in the cytoplasm. So from mitochondria, cytochrome C is leaking now. So what will this do? It's going to activate caspases, right? So that's caspases. So that's how it activates that. What does this one do? How does it tell? How does it prevent apoptosis or caspases? BCL2 keeps the mitochondrial membrane impermeable. Okay, so it doesn't let anything go by, thereby preventing cytochrome C release. So BCL2 overexpression, for example, in follicular lymphoma, this is T1418, will cause decrease in caspases activation, which will cause tumor genesis. Because now it's just gonna, you know, it's not gonna die. So it's gonna keep on living and splitting and living and splitting, right? And all the ones that it's making are also gonna have overexpression of BCL2. So that's how you get tumor genesis. Then you have extrinsic death receptor pathway. You have two pathways: ligand receptor interactions. FASL binds to FAS or CD95, or TNF alpha binding to its receptor. And then you have immune cells, cytotoxic T cells, release of perforin and granzyme B. Okay, so we have FASL combining to FAS, okay, and you have TNF alpha at the TNF receptor, and both of these things will initiate caspases. Okay, know about this and this system. Um, there's also one more, but it's not given here. Probably somewhere else. FAS and FASL interaction is necessary in thymic medullary negative selection. Okay, so FAS and to FASL interaction is necessary in thymic medullary negative selection. So remember, this is where T cells are getting matured, right? Negative selection is where they split between CD8 and CD4 T cells, and they become from immature to mature T cells, right? So that this is what it's important for FAS to FASL, the maturation of T cells in, because medullary M was for mature, cortex in the thymus is for immature cell, and immature T cells are just the ones that have all three, CD4, CD8, and the third one that I think was like CD3 or something like that. It's found on everything. But the main thing is that CD4 and CD8 together on one cell is immature. So then you need the negative selection, right? So negative selection causes the maturation in the medulla of thymus. Autoimmune lymphoproliferative syndrome caused by defective FAS to FASL interaction So failure of clonal deletion. This will cause increased number of self-reacting lymphocytes. Presents with lymphadenopathy, hepatosplenomegaly, and autoimmune cytopenia. Okay, so what does this do? Uh, when caspices are initiated, you have cytoskeleton dispersion, and then they get all, enter the cytoplasmic pleb. You get the nuclear fragmentation also going into the pleb, and then you have so when all of this is happening and the pleb is going, the receptors, the ligands for macrophage cell receptors are going to attach to macrophages receptor for that. And this is the apoptotic body, so it's going to get gulped up or phagocytized. And then you also have cytotoxic T cells, the CD8 T cells, coming in with the granzyme B, releasing its porphyrins to destroy everything. Okay, you should know what caspase is and what its function is. Its function is basically to destroy the cell itself and cause apoptosis, right? So they they might talk about like there is a something got attached to the receptor, and then it caused release of certain enzymes that were causing degradation from the inside. What initiated this whole, or what is this? Which enzyme or which enzyme? So it's the cytosolic proteases. So which enzyme is responsible for this destruction or degradation, right? It's the caspases. That's what's responsible. And caspases also seems like it's Casper, right? Okay. Necrosis. Necrosis is also an important concept, but mainly for the brain and solid organs. So you will see what that means. So necrosis is exogenous injury. Uh, okay. So necrosis is exogenous injury, which leads to plasma membrane damage, which leads to cell undergoing enzymatic degradation and protein denaturation. Intracellular components leak, so this will cause local inflammatory reaction, unlike apoptosis. Okay, apoptosis causes no reaction, while this one will cause the inflammatory response. Okay, so you have something coming from outside damaging it, and then the plasma membrane is damaged. Then the cell undergoes enzymatic degradation because the damage. So you have like lysosomes and everything leaking out, and cytochrome C and all that stuff. So this will cause protein denaturation and intracellular components leak outside. Now that all the components are outside, it will also cause the inflammation, not only in the cell, these ones, but also outside the cell, right? Unlike apoptosis. So there are like 5 types: one, two, three, four, and five. Oh, six. Sorry. So there's 6 types of necrosis, and they all basically do the same thing, but since it's in the different parts of the body, uh, it looks different. They all don't look the same. Like brain is liquidy, right? It's not gonna look the same as caseous or coagulative, which is in like solid stuff, right? Infracts. So that's why it's different, but the mechanism is same. That's why it's all under necrosis. So coagulative, it's seen in ischemias or infracts in most types except brain. Uh, it's due to ischemia or infraction. Injury denatures the enzymes, which leads to proteolysis blocked. Okay, so histology, preserved cellular architecture, cell outlines is seen, but nuclei disappears. So increase in cytoplasmic binding of eosin stain because of increase in eosinophilia, which is red or pink color. Okay, then you have liquefactive. Uh, you should, I guess, we should look at this. So it's gonna look like that. It's not a good example. It's a granuloma. But yeah, because granuloma happens in these areas as well, right? Okay. Uh, so all of these cells don't have nucleus in them, right? That's what you're supposed to know. Like that's how you're supposed to differentiate between everything. Whereas you see a little bit of nucleus over here and here and here, the blue stuff, but you don't see any of that here, and it's pink. Okay, so histology, preserved cellular architecture. So you see the outlines, right? You can see that these were cells, but nuclei disappears, so there is no nuclei here. Right? Increase in cytoplasmic binding of eosin stains. So you'll see a lot more eosin stains here. Okay, the pink and red. Okay, cool. Then we have liquefactive bacterial abscesses or CNS influx. Uh, this is due to neutrophils released lysosomal enzymes that digest the tissue. Right, so just that one right there. Okay, let's just do. Okay, so that's what that looks like. So neutrophils also release all the enzymes like proteases and I can't recall right now, but everything that like cleaves and degrades and all that stuff. Um, so lysosomal enzymes, exactly. Okay, that digests the tissue. Okay, so early cellular debris and macrophages are going to be seen, and in the late liquefactive necrosis, you'll see cystic spaces like that and cavitations in CNS. Neutrophils and cell debris seen with bacterial infection. Because macrophages will take care of all the debris and stuff, right? But after it eats away everything, it doesn't regrow or recover or anything, right? So you'll have cystic spaces and cavitations. So neutrophils and cell debris seen with bacterial infection. Okay. Then you have caseous. This is in TB or systemic fungi, for example, histoplasma of capsulitum and nocardia. Macrophages wall off the infecting microorganisms, which cause granular debris. Fragmented cells and debris surrounded by lymphocytes and macrophages. Again, it's just granulomas, right? So cheese-like gross appearance. They might tell you it's cheese-like consistency. What can it be? So it's going to be your caseous necrosis. You should also pay attention to where it's found, because that also gives away what it is. Okay. Then you have fat, enzymatic acute pancreatitis, so saponification of peripancreatic fat. And then you have non-enzymatic, which is traumatic, for example, injury to breast tissue. So women with pendulous breasts, when they run without like support, they can end up with this kind of uh, non-enzymatic traumatic fat necrosis, which is benign, but it can be mistaken for like breast cancer. So they have to get it looked at because they might feel the lump, basically, right? Okay, and it's usually on the upper right quadrant or upper left quadrant. In the question stem, it's usually on the upper right quadrant. There is a mass, and then it's usually this, and they'll say there's a mass on the upper right quadrant, but there's no lymphadenopathy, right? So then it's not cancer. But if there's lymphadenopathy and there's a mass there, then it's usually breast cancer. Damaged pancreatic cells release lipase, which breaks down triglycerides. Liberated fatty acids bind calcium, right? So there's saponification, chalks, white appearance. Okay, so again, damaged pancreatic cells release lipase, which breaks down triglycerides. So liberated fatty acids bind to calcium, saponification. Another concept of basically oxalate stones is that when you have pancreatitis, you don't there's malabsorption of fat, right? So you don't absorb the fat, so it goes out in the stool. When you have too much stool with fat, what happens is calcium from calcium oxalate. Normally, calcium binds to oxalate, right? And that's how it's regulated. But then, when this happens, calcium has more affinity for fat than oxalate, so it's gonna bind to this fat, right? So that's how you get free oxalates, and then the oxalate travels through the body up to the kidneys, where it's gonna find more calcium just around there, and it's gonna start making stones there. So that's how you get calcium stones. Hold on, no, I got that wrong. What does it bind to? How do you get oxalate stones? Let me look that up. Okay, so calcium, which normally binds to oxalate, binds fat instead, so free oxalate absorbed by the gut. So increased frequency of calcium oxalate kidney stones. Yeah, there you go. So normally calcium oxalate doesn't go to kidney when it's together, but when oxalate by itself goes to the kidney, you will have calcium oxalate forming there, and then you'll have the stones because then it can't escape anywhere, and that's why you get the calcium oxalate stone. So that's important to know. Where's the necrosis going? Okay, I'll just find it. Okay. So we were doing fat. So again, damaged pancreatic cells release lipase because lipase and amylase are released by pancreas. But there's also amylase in the saliva as well. So if you're trying to do, uh, pancreatic function test, you're gonna check for lipase and not amylase because amylase is also released by mouth, saliva, right? So lipase, which breaks down triglycerides, liberates fatty acid, binds to calcium, which leads to saponification, chalky white appearance. So outlines the deaths of dead fat cells without peripheral nuclei, saponification of fat combined with calcium. Appears dark blue and H&E stain. So that's D. That it's not gonna help you much, and they won't give you a histo for this. Just know that the it can be mistaken for breast cancer. Know that. And in pancreatitis, it releases lipase. Okay. And saponification. They might give you this that there's a chalky white appearance found near the or around the pancreas. What can it be? It's fat necrosis. That's what it is. Okay. Fibrinoid, immune vascular reactions, for example, PEN. Non-immune vascular reactions, for example, uh, hyper hypertensive emergency preeclampsia, right? So when it's saying immune vascular reaction, is talking about vasculitis. The PAN is the periarteritis arteritis nodosa, and then non-immune vascular reactions are the hypertensive emergencies or preeclampsia. So uh, why does it happen? Immune complex deposition of type 3 hypersensitive reaction. That's type 3 hypersensitive reaction, right? Immune complexes. That's with the Arthur's reaction and serum sickness. And or plasma proteins, for example, fibrin. Leakage from damaged vessels. Okay. So anything like this will cause either immune response or non-immune response, which can lead to fibrinoid necrosis. Uh, so you'll see vessel walls contain eosinophilic layer of proteinaceous material, like that. Okay, so that's the artery, right? And normally artery has like 3 layers, and this is inner, middle, and outer, or intima, medial, and externa layers. And here, and when you have vessel wall contains the fibrinoid one, you're not going to be able to differentiate it. It's going to be thicker as well, as you can see, and it's surrounded by non-epithelial cells that you can see, because it doesn't look like it's an epithelial cells, right? Because that's what you have on the inner side of the artery. So normally, what a normal artery looks like. So that's what a normal artery would look like, right? When you look at it. This is vertical. Anyways, you can differentiate the layers basically, right? There's a lot more layer here. So this layer is different than this layer. This layer is different than this layer. You can tell it, tell the difference, but in this one you can't tell the difference because it's all the same. So that's fibrinoid necrosis. Gangrenous distal extremity and GI tract after chronic ischemia. So there's dry, which is ischemia because of ischemia, like that, and then there is wet, which is super infection, like perfringens, right, causing gaseous gangrene. So that would be wet. If it's dry and ischemia, due to ischemia, uh, this happens when, like, say you're out in, like, I lived up in Fort McMurray in Alberta, and we used to have cases of, like, people losing their nose and toes and stuff because the temperature went down to like -40 to -55. And if you stand outside in that much cold without protection, longer than like 20 minutes, you'll start losing blood. Why? Because cold makes your vessels constrict, right? So there's vasoconstriction happening in cold. and it's to the amount where uh, you're losing all your blood supply to the extremities and your nose and even your earlobes. So, because those get cold the most and the fastest, because everything else is closer to the heart, so it can get your core heat supply to that. But by the time it reaches to the extremities and all that stuff, uh, it just the ways of constraining it doesn't have the power to go through it, so you get necrosis or gangrene because of that. And then the only thing you can do is break it off, unless you know, or yeah, you can wear protection and stuff. Um, okay, so coagulative is wet superinfection and is liquefactive superimposed on coagulative. Okay. Uh, Now we are gonna do ischemia. Ischemia is, you already know, uh, inadequate blood supply to meet demand. Mechanisms include decrease in arterial perfusion, for example, atherosclerosis. That's just buildup of plaque made of cholesterol and all that stuff. So this is why it's not good to have high cholesterol, basically. It's because of this that causes coronary artery diseases. Decrease in venous drainage, for example, testicular torsion, Budd-Chiari syndrome, and shock. Right? Regions most vulnerable to hypoxia, ischemia, and subsequent infractions. Okay. So, by the way, Budd-Chiari syndrome is like in the liver, if you know. In testicular torsion, it very the very the veins in your testes get all wrapped up around the spermatic cord, or vice versa, and then it stops the supply because of that. The vessels cannot supply to it, and that's why it's an emergency condition. Because if you don't take care of it, you have to get rid of it. Uh, but Curie will read that in GIT. And shock. Shock just normally is hypovolemia, so you don't have enough blood volume to pass on oxygen to every single organ and perfuse it adequately. Right. So all of this was cause of ischemia. Okay. Uh, in ischemia, you need to also know like just a different concept, like trailing off, but you should know what perfusion pressure is, saturation of oxygen is, and what is hypoxia and what is hypoxemia, right? You should know all of these terms. Uh, so brain regions where it gets ischemia, it can get ischemia more commonly is anterior cerebral artery, middle cerebral artery, and posterior cerebral artery, the boundary areas, also known as the watershed areas, right? Heart, subendocardium of left ventricle, yellow lines in A. So that part right there, outlined by subendocardial infraction. So that's subendocardial infraction. Okay, kidney. So we'll do that when we come to CVS. Kidney, straight segment of proximal tubule, medulla, thick ascending limbs, which is also in medulla. This is important. Remember that, because they will ask a question like, this person was stranded outside for like 3 days, and or like 2 days without water, and he's extremely dehydrated, and all that stuff, and then they'll ask you, in case that there's ischemia or something, or maybe not like stranded outside, but like on a mountain or something. I don't know, where there's less oxygen and all that stuff as well. They ask for that as well. So they'll be like, which one is more prone to damage? Which area in the kidney is more prone to damage when there's low partial pressure of oxygen? So it's these areas. Straight segment of proximal tubule and thick ascending uh, limb. So just a quick thing. This is your glomerulus, and then it goes into uh, your proximal tubule. This is thin descending and then thick ascending, descending to thick ascending to then distal convoluted tubule, and then your collecting duct like that. Okay. So okay, I should have said, but the bottom part and the proximal part is all part of medulla. So that is the part that gets ischemic. Liver, it's around central vein zone 3. It's the innermost part. So we think of it like a triangle when we think of zones. So if it's like that, yeah, sure, let's do that. And then you have zone 1 on the outside, and then you have zone 2 on the inside, so like that. So this would be zone 1, zone 2, and this would be zone 3, the closest to the central artery or central vein, right? So this is where the central vein is. Then you have your bile duct and your portal artery and vein over here. So the closest to the central vein, because all the oxygen gets used up before it gets there, so that one is more prone to ischemia. Okay. So let's get rid of that. Then colon. Colon only has two, but after kidney, this is the most important one. Or I guess after this one, it's kidney, the second most important one to know. Colon, it's splenic flexure, Griffith point, or rectosigmoid junction. I'll just show you where those are. Splenic flexure is right under the spleen. Right, so your spleen would be up here, so it's right under it. That's why it's called the splenic flexure. So that part, and the sigmoid colon is right here, the one that's making the S. So that part. Okay. Trying to see if there's like a better one. But anyways, so inferior mesenteric and hypogastric watershed. So this is the watershed area. Like this. I believe it's up here, not here, but okay. Never mind, it is probably here because it's getting supplied by these arteries. Inferior mesenteric arteries. These one gets supplied by something else, I guess. And then up here. So normally when you say watershed, what it just means is basically it's the area between so say this artery supplying something like that and like that, right? And there's another artery coming in and supplying here and here, here, here. And this whole thing is the organ. Okay. So it's the area between the two areas of supply of artery. So this would be the watershed because this one is supplying majorly on this side, and it's going to think that this one is going to take care of the rest of it, and this one's going to supply this side, and it's going to think that this one's taking care of it. So they're like really small capillaries in the middle that's taking actually care of all of this area. But by the time all this blood gets to that area, it's going to be very minimal oxygen, and that's why it's called the watershed. So those areas would be the first one to get hurt in oxygen deprivation. Okay, I guess they explained it here. Watershed areas. Water areas receive blood supply from most distal branches of two arteries, right? So most distal branches of two arteries with limited collateral vascularity, the capillaries. Uh, these areas are susceptible to ischemia from hypoperfusion. Neurons most vulnerable to hypoxic ischemic insults include Purkinje. 10 minutes, okay. Let's finish this page. Um, Hypoxic ischemic insults include Purkinje cells of the cerebellum and pyramidal cells of the hippocampus and neocortex. Okay, so neurons most vulnerable to hypoxic ischemic insults include Purkinje cells of the cerebellum and pyramidal cells of the hippocampus and neocortex. That's why hippocampus is the one that makes memories, right? Neocortex is like for, I don't remember at this point. And then you have Purkinje's on the cerebellum. That's the one that uh, does your balance and coordination and all that stuff, right? So it affects all that stuff, memory and coordination and balance and all that stuff when you don't have oxygen. That's why in movies, when you see someone going into like low oxygen area, they trip and stuff and they can't remember what to do, or like even when you're trained under high pressure uh, and you have training, even then they don't remember what to do when such thing is happening. It's because your hippocampus gets affected as well. Types of infarcts. Red infarct occurs in venous occlusion and tissues with multiple blood supplies, for example, liver, lung, intestine, and testes, and with reperfusion, for example, after angioplasty. Uh, so, okay, again, occurs in venous occlusion and tissues with multiple blood supplies, for example, liver, lung, intestine, and testes. At least these ones are solid. Intestine is a iffy one. You might not remember that, but you can remember liver, lung, and testes, right? Uh, there's a difference between red infarct and pale infarct. So, what is the difference? Reperfusion injury is due to damage by free radicals. Okay, so that's why you get the red infarct like that. It's also called the wedge infarct, I think. Uh, and then you have pale infarct, occurs in solid organs with a single end arterial uh, blood supply. So let me just look that up. So that's what it looks like. It kind of looks like a wedge. Let's see which one's a good example. I guess maybe I got my wedges wrong. But okay, so that's what a red one would look like, and they'll give you a photo like this. So then, what is a pale infarct? Okay, this is the wedge one then, right? So it happens in kidneys and anywhere, actually occurs anywhere. It occurs in solid organs with a single and arterial blood supply, like heart or kidney. Okay, there you go. So this is known as the wedge infarct. Okay, and look at some photos of that in the break if you want, and we'll just continue back. Pale infarct, also known as wedge infarct, or yeah, wedge infarct. And normally they give you a photo for kidney with the wedge infarct, and you should know what kind of infarct it is. It's the pale infarct. So, free radical injury. Free radicals damage cells via membrane lipid peroxidation protein modification, and DNA breakage. So these three things. First, the lipid peroxidation, then the protein get modified, and then the DNA break. So these three mechanisms is how free radicals cause damage. Initiated via radiation exposure, for example, cancer therapy or metabolism of drugs, phase 1, redox reactions, nitric oxide, for example, inflammation, transition metals, for example, iron, copper, form free radicals via Phantom reaction. Uh, just so we know what Phantom reaction is. It's this one. Uh, um, okay, so you know how you have O2 with the uh, in the respiratory burst. So O2 becomes superoxide with NADPH oxidase, and then you have superoxide dismutase making peroxide, right? Hydrogen peroxide. So with that, when you have Fe2 plus adding to it, it will cause hydroxide and OH and HO ions, I guess, or molecules. But this is known as the Phantom reaction. Uh, so superoxide dismutase is right here. So superoxide becomes peroxide, and then with myeloperoxidase it makes some bleach. But on this side over here is the Phantom reaction with Fe2 plus. It makes OH. Okay. Okay, so that's what that was. Once again, initiated via radiation exposure, for example, cancer therapy, metabolism of drugs, phase 1, redox reactions, nitric oxide, for example, inflammation, transition of metals, for example, iron, copper, uh, form free radicals via the Phantom reactions, WBC, for example, neutrophils and macrophages, right, and WBC oxidative bursts. So oxidative burst happens in this and neutrophils and stuff like that, right? So that free radicals can be eliminated by scavenging enzymes, for example, catalase and superoxide dismutase, glutathione peroxidase, spontaneous decay, antioxidants, for example, vitamin ACE or vitamin A, C, and E, and certain metal carrier proteins, for example, transferrin or ceruloplasmin. Okay. Uh, this is why, also a reason why people take vitamin C when they're sick or they're prescribed vitamin C. Uh, Even in COVID, they were given vitamin C a lot because it takes care of free radicals in case there is an infection other than just COVID. Spontaneous decay antioxidants, and uh, yeah, vitamin E is pretty good for like hair and like skin and stuff as well. So you'll find that in lotions and uh, shower gels and stuff like that as well. Vitamin A is retinol. We use that for like acne, right? So retinol serum or isotretinoin, like that. So it's because of their antioxidant properties. And certain metal carrier proteins, for example, transferrin and ceruloplasmin. Okay, so examples: oxygen toxicity, retinopathy of prematurity. This is important. Why? It's basically saying that when you give a baby, a newborn, 100% oxygen, they have a risk of this retinopathy of prematurity because we give oxygen to whom preemies, right? That so there will be abnormal vascularization, right? So they'll have new vessels forming in the eye. So that's called retinopathy of prematurity when you have a lot of oxygen. Uh, Bronchopulmonary, because why this happens, the mechanism is basically the body was deprived of oxygen. Now it all of a sudden it has a lot of oxygen at once. So where the oxygen was going, it's gonna have a lot more oxygen going through that place. So and it doesn't need that much. So what it's gonna do is gonna try to distribute it around it as well. So that's why you get new vessels forming in those areas, and that's the cause, I guess. Bronchopulmonary dysplasia and reperfusion injury after thromboembolic therapy. By the way, that was just my explanation, but it's actually VEGF that's responsible for this vascular endothelial growth factor. VEGF. Okay, so remember that retinopathy of prematurity is because of VEGF. Bronchopulmonary dysplasia, reperfusion injury after thromboembolic therapy. Reperfusion, sorry, reperfusion injury after thromboembolic therapy. So this is basically like, say you have a blockage in your coronary artery. So after you take away the blockage with antithrombotics, uh, the blood will come in, but everything. Okay, so let me try that out. Or actually, let's just search up an image. So, say there was a blockage in the vessel over here, right? The blood can't go through. So what's gonna happen here? It's gonna be deprived of oxygen. When something is deprived of oxygen, what's it gonna do? It's gonna make anaerobic reactions, right? So that's your lactic acidosis and all that stuff. So along with lactate, it makes other stuff, and there are other reactions that causes toxicity of some kind, right? So that toxicity gets built up until uh, and it stays there as long as the blood is not flowing through it. But then when this blockage is cleared off with like antithrombosis, or say there was a plaque or something, and you remove it physically with a wire or something. Oh, sorry. What's gonna happen? This blood is now gonna go flow through here, and it's gonna supply the blood, or is at least gonna try to supply it over here. So now it's gonna get mixed up with all the toxins that were getting made with lactic and all other waste products and all that stuff, and that's gonna go throughout the body and cause the reperfusion injury. I say body, but in heart, it actually just circulates around the heart as well, and it causes like other symptoms. We'll learn about that in CVS. Okay. Whoa, what just happened? Oh. Okay, so right. So okay, sorry about that. Bronchopulmonary dysplasia, reperfusion injury after thrombolytic therapy. So just explain what that is, and explain what this is. Uh, Bronchopulmonary dysplasia is just uh, in the lungs. It causes changes in the lining, I guess. Drug and chemical toxicity, acetaminophen overdose or hepatotoxicity, carbon tetrachloride converted by cytochrome P450 into CCl3 free radicals. This will cause fatty liver. Cell injury. This causes decrease in apolipoprotein synthesis. We remember what that is. And fatty changes. Central lobar necrosis. Basically, apolipoproteins are the ones that are required to transport triglycerides and chylomicrons and stuff like that, right? So if you have that, what's gonna happen if you don't have this lipoprotein? It stays in the lining, right? Central lobar necrosis, metal metal storage disease, hemochromatosis, iron, and Wilson's disease, right? So everything that's part of this thing that they were explaining over here. So hemochromatosis and Wilson's disease will also cause free radicals by the Phantom reaction. So yeah. Okay. So ionizing radiation toxicity. Ionizing radiation causes DNA. For example, double strand breaks and cellular damage, both directly and indirectly through the production of free radicals. Okay. Yeah. Complications usually arise when the patient is exposed to significant doses, for example, radiotherapy and nuclear reactor accidents. Local, so this is going to cause you localized inflammation and fibrosis, or also neoplasia, for example, leukemia or thyroid cancer, right? Now we're going to talk about the acute radiation syndrome. So exposure to ionizing radiation, including therapeutic or palliative radiation therapy, induces DNA damage through DNA double-stranded fracture and the formation of oxygen-free radicals. Okay, the important thing here is this part right here. Ionizing radiation causes DNA double-stranded fractures. Okay. So acute radiation syndrome develops after sudden whole body exposure to high doses of ionizing radiation. You'll get nausea, vomiting, diarrhea, hair loss, erythema, cytopenias, headache, altered mental status, or status, yeah, status. Stem cells of rapidly regenerating tissues, for example, skin, bone marrow, GI tract, gonads, right? So these are the most susceptible to radiation injury. So this is an important line to know. Remember this, that it's the stem cells of rapidly regenerating tissues. These are the tissue, wherever you're gonna find this, it's where, like your GI tract, it keeps getting friction or rubbed off by the stool passing by. So you'll have a lot of cells getting damaged and then, or getting ripped off from your intestines and stuff. So it requires stem cells there, so it makes more cells continuously. Similarly, in bone marrow, you needed to make the lymphocytes, leukocytes, sorry, and erythrocytes and all that stuff. Skin, everyone knows that skin, like, this is where you get the dead skin dust in your house. And gonads makes sperms and stuff, so it needs that. So these are the areas where radiation affects the most. So these are the most susceptible to radiation injury. Radiotherapy damages cancer cells more than healthy cells because cancer cells have dysfunctional DNA repair mechanisms in addition to high replicative rates. Okay. So our body can handle radiation to up to a certain limit because we can repair it, but cancer cells are dysfunctional to start off with, right? So they don't have the repair mechanism. So radiation, when it breaks their DNA, uh, they're not gonna get repaired. That's how radiation works. We'll learn about chemo later in, I guess, HEMAT. Types of calcification. Calcium deposits appear deeply basophilic. Okay, so like that on H&E stain. So there's dystrophic calcification and metastatic calcification, right? Dystrophic calcification is again the one with the breast, where you get the damage over there and it's mistaken for breast cancer. So know about dystrophic calcification. That's what it's gonna be if it's not cancer. Okay, so you get calcium deposition there. That's why it gets picked up in the mammogram as well. And so calcium deposition in abnormal diseased tissues extent tends to be localized. For example, calcific aortic stenosis. Associated condition is tuberculosis, lung, and pericardium, and other granulomatous infections. Liquefactive necrosis of chronic abscess, fat necrosis, influx, thrombi, schistosomiasis, congenital CMV, toxoplasmosis, rubella, pneumoma bodies, CREST syndrome, atherosclerotic plaques can become calcified as well. This one is major. Uh, you need to know about that, CREST. That's like what was it? Calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Right. Pneumoma body also has it, but we'll do that when we come to it. Okay. Like it also has an acronym for that, so you know where it is. Metastatic calcification in normal tissues, right? Calcium deposition is in normal tissues and metastatic calcification. Because what does it actually mean, right? It's just uh, metastasized calcium, I guess, right? In normal tissue. So extent, it's widespread. For example, it can be diffuse, so everywhere, and it can be metastatic, going through to the wherever the artery takes it. Associated uh, conditions are predominantly in interstitial tissue of kidney, lung, and gastric mucosa. These tissues lose acid quickly, increase pH favors, and pH favors increase in pH favors the calcium deposition as well. This is why you get the calcium stones as well uh, when you have alkaline urine. Uh, Nephrocalcinosis of collecting ducts may lead to nephrogenic diabetes insipidus and renal failure. Um, we'll learn about this in renal. Etiology secondary to hypercalcemia, for example, primary hyperparathyroidism, sarcoidosis, hypervitaminosis D, or hyperphosphatemia, for example, chronic kidney disease. Serum calcium levels are usually abnormal, so you'll have a lot more because it's spreads via blood, right? So it's going to be picked up more in the serum, so that's why you're going to have high levels of it. Whereas here, it's not in the blood; it's somewhere in the tissue, so you won't have it in the blood. That's why you get normal calcium level, even though there's a lot of it deposited everywhere. Lipofuscin. This thing, it's important to know the history for this. So the history is going to tell you if whether it's this or it's like heart failure cells or hemochromatosis. It can be anything unless you have the history for this, right? So history is very important to diagnose it. And it's lipofusion. So what is this? It's a yellow-brown wear and tear pigment. That's all it is. It's nothing uh, malignant or anything. It's just benign pigment, right? And that's literally what it looks like. Let's have some more examples. So there's brown pigment that you see. Right? That as well. So this can it might look like it's something else. This is striated muscles, but they might show it to you in like cardiac muscles or stuff, and it might look like it's you know skeletal muscles again. But yeah, so that's what it is. Yellow, brown, wear and tear pigment associated with normal aging. So as you age, it's it's there in each person. The question would have like there was a 74-year-old and they did the autopsy on him and they found this kind of pigment on a lot of organs like the kidney, liver, lungs, uh, and so what is it? So you had you have to remember that this dude was 74 years old. So 74-year-old will have the wear and tear pigment. If it was like someone younger, then you're not going to do lipofusion for that, right? And they're not going to be like, okay, it was 54 or 64. They're going to give you someone about 70. So it's like surely someone who has aged. Uh, Composed, and it's not like someone who smokes them while they're getting older. It could be anyone, right? Because it's normal aging. Composed of polymers of lipids and phospholipids complexed with protein, may be derived through lipid peroxidation of polyunsaturated lipids of subcellular membranes. Autopsy of older adults will reveal deposit in heart, colon, liver, kidney, eye, and other organs. Okay, so they gave it to you here. So autopsy of older adults. This is usually how they can figure it out, right? Because you're not gonna look for these in like a live person. Even if you find it at one place, you're not gonna find it everywhere. So it's gonna be an autopsy, and then it's gonna be an adult. Okay. Amyloidosis. Uh, this is also important for a couple of things. But okay. So remember, in light chain it's AL, and in inflammation it's AAA, or AA. Sorry. Okay. So amyloidosis is abnormal aggregation of proteins of or their fragments into beta-pleated linear sheets. Insoluble fibrils, cellular damage, and apoptosis. So insoluble fibrils will cause cellular damage and apoptosis. Amyloid deposits visualized by Congo red stain, red-orange on non-polarized light. So that's these things. Gotta look at it. I'm not sure. Okay, so I guess these things right here would be the. Okay, so these things are the amyloid deposits. Is the one in the middle, right? And there's a glomerular or glomerulus in the kidney. So, okay. So that and this look way different, but I guess they won't give you this, or they could, for kidney and renal. But they'll give you some history to it too, so that'll help you figure it out as well. And then if they just give you this apple green birefringes, they don't use this for a lot of things. So So there's only a couple of things that they'll use this for. So then you can just think of amyloids for this. Right? Main thing for this is it's going to be asked in Alzheimer's and kidney. That's the majority of the times this is going to show up, or multiple myeloma, but that's a different one. Okay, so common types: febrile protein description and notes. Systemic primary amyloidosis is AL from immunoglobulin light chains, right? So L for light, seen in plasma cell disorders, for example, multiple myeloma. There you go. So AL will be, if you see this, or if they tell you it's light chains found, what can be? It's usually multiple myeloma, right? Then there's secondary amyloidosis. It's when the serum has amyloid A. So it's seen in chronic inflammatory conditions like rheumatoid arthritis, inflammatory bowel disease, familiar Mediterranean fever, and protracted infection. So you can remember this one. Different color. Inflammation. Right, so AA. So secondary one, or AA, two A's, right, are inflammation. Primary one is P, so it's going to be for plasma cell disorders like multiple myeloma, which has AL, L for light chain. So that leaves dialysis related amyloidosis. You'll remember these two, but then you'll forget about this one. So remember, the fibroprotein, which they'll give you probably, is B2 microglobulin. So it's seen in patients with end systemic renal disease, end stage renal disease, and or on long-term dialysis. Uh, it's going to be this one mostly. They'll tell you this person is on dialysis for a long time. It's usually they're on dialysis because they have kidney disease, right? But if they're on dialysis, majority of the time they're trying to hint you that it's amyloidosis. Manifestations include cardiac, which is restrictive cardiomyopathy, GI, for example, macroglossia, hepatomegaly, renal nephrotic syndrome, hematologic, for example, easy bruising. Oh yeah, so when I said renal is where it's gonna show up, it's gonna show up because of like in nephrotic syndrome. Okay, hematologic, for example, easy bruising, splenomegaly, and neurologic, for example, neuropathy. Musculoskeletal, for example, carpal tunnel syndrome. Okay, so carpal tunnel syndrome, okay, and neuropathy, easy bruising, and splenomegaly, nephrotic cardiomyopathy. Remember these because all of these diseases do show up, and they'll be like, they found something, and what can it be? If nothing makes sense, it's probably amyloidosis. Okay, so localized. So Alzheimer's is because of beta amyloid protein cleaved from amyloid precursor protein, right? This is important. Then you have type 2. So if there's amyloid deposition in the pancreas, islet amyloid polypeptide (IAPP) is caused by deposition of amylin in pancreatic islets. Then if it settles in the thyroid, you have medullary thyroid cancer. You'll have calcitonin, right? Calcitonin is like the opposite of PTH, I think. Oh, yeah, and so it lowers the calcium level in your body, whereas PTH would increase the calcium level in your blood, right? So then you have isolated atrial amyloidosis, ANP is the one. So common in normal aging, but it increases risk of atrial fibrillation. Okay, ENP is the one which controls the blood volume if you have hypertension and all that stuff in your heart, at least. That it gets released in the atria, I guess, the right atria. We'll do that in CVS. Systemic senile age-related amyloidosis is normal wild-type transthyretin or TTR, seen predominantly in cardiac ventricles, and cardiac dysfunction more insidious than in AL amyloidosis. Okay, so in systemic senile amyloidosis, it's gonna be more serious. So in this, know about Alzheimer's at least, and just know that if it settles in on pancreas, that is what causes type 2 diabetes mellitus. Because they might ask you pathogenesis of type 2 diabetes, DM, right? So you should know this. They don't normally ask you about these. They instead ask you about multiple myeloma or the inflammatory, and definitely the renal is gonna show up there. Everywhere else, you'll get like one or two questions somewhere in some question banks. You might get more, but I'm talking about like UWorld. Okay. Hereditary familial amyloid cardiomyopathy, mutated transthyretin or ATTR. This is one where we have to get it. Sorry. Ventricular endomyocardium deposition leads to restrictive cardiomyopathy and arrhythmias. Okay, and then you have familial amyloid polyneuropathies, mutated transthyretin or ATTR. Again, same thing, due to transthyretin gene mutation. Just know this. So, mutated transthyretin can be inherited, or it can just cause spontaneously. Okay. Inflammation. Some of this stuff we already went over, like in immuno. So we'll be quick. Inflammation responds to eliminate initial cause of cell injury to remove necrotic cells resulting from the original insult and to initiate tissue repair. Divided into acute and chronic. Right. Okay. So acute inflammation and chronic inflammation. The inflammatory response itself can be harmful to the host if the reaction is excessive. For example, septic shock. Prolonged if it's, for example, persistent infections such as TB. Or inappropriate, for example, autoimmune disease such as SLE. Okay. Signs and mechanism, cardinal signs, rubor and calor, or calor, is just redness and warmth. Vasodilation will happen, relaxation of arteriolar smooth muscle, increase in blood flow mediated by histamine, prostaglandin, bradykinin, and nitric oxide. All of this causes the swelling to be warm, right? So remember that. This is important because you can have swelling that is not warm, and you need to know when that happens as well. It's usually staph abscess and granulomas you have to differentiate with, just these two. Right? Okay, so tumor, swelling, endothelial contraction disruptions, for example, from tissue damage, increase in vascular permeability, So leakage of protein-rich fluid from postcapillary venules into interstitial space, exudate. So you have increase in interstitial oncotic pressure. Endothelial contraction is mediated by leukotrienes, C4, D4, and E4, histamine, and serotonin. You have dolor, which is pain, uh, sensiti- sensitization of sensory nerve endings, mediated by bradykinin, PG2, and histamine. Mm, So that's important, I guess, but I don't think you'll be tested on any of this stuff. It's just to make your basis clear. Functiolessa, or loss of function. Inflammation impairs function, for example, inability to make a fist due to hand cellulitis. Okay. So these are the cardinal signs of inflammation. For systemic infection or inflammation, you have acute phase reaction, right? So that's IL-6 normally that does this. Remember, hot T-bone steak. So hot was IL-1, that causes fever. T-bone steak was 2, because it stimulates, interleukin 2 stimulates T cells. And then you have uh, bone for bone marrow, so it stimulates bone marrow, IL-3. And then you had EA and K, so IL-4 and 5 does, what would they do? E and A, and then K was for IL-6 was for this acute phase reactant. E was eosinophils, I think. It stimulates that, right? IL-5, yeah, right. So IL-5 makes that, and what was IL-4? Anyone remember? It's gonna help me now. IgG and IgE, right? Okay, cool. Thanks. Okay, so uh, right. So I have 4 was IgE, and right, and then 5 was IgG. So IgE would also stimulate eosinophils or attract them or recruit them as well, right? Okay. Systemic manifestations, acute phase reacting. Again, fever. So already went over this. Pyogens. Uh, so LPS does it via uh, 3 things, right? IL-1, IL-6, and tumor necrosis factor. So that was IL-1 causing fever, IL-6, and TNF, which causes fever and decrease in BP. So we did that over there. So pyrogens, LPS, induces macrophages to release IL-1 and TNF, which causes increase in COX activity in perivascular cells of anterior hypothalamus, which causes increase in PGE2, uh, which leads to increase in temperature set point. Okay. Leukocytosis, increase in WBC count, type of predominant cells, depends on inciting antigen or injury. For example, bacteria will cause increase in neutrophils. This is important because this is how we diagnose meningitis, right? Like the culprit at least. So if it's neutrophils, it's going to be bacteria. If it's lymphocytes, it's going to be either fungal or viral. And then you look at the glucose levels, because fungus requires glucose, so it's going to be decreased. But virus doesn't need glucose for energy, so it's going to stay normal. Increase in plasma acute phase reactants. Serum concentrations significantly change in response to acute and chronic inflammation. Uh, Produced by liver, notably induced by IL-6. Give me a sec. Need a water break. Okay. So serum concentrations significantly change in response to acute and chronic inflammation. It's produced by liver, notably induced by IL-6. So the major one is CRP that we look at, right? So acute phase reactants, what are they actually talking about? Uh, Positive or upregulated. So CRP is usually the one we look at when we do blood tests to figure out if there is any inflammation or not. And that will tell you if there is some kind of inflammation in pancreas or muscles or something like that. Opsonins fixes complement and facilitates phagocytosis, uh, okay, and measured clinically as a non-specific sign of ongoing inflammation. Right? Then you have ferritin. It binds and sequesters iron to inhibit microbial iron scavenging. It's important in chronic infections. Fibrinogen, coagulation factor, promotes endothelial repair and correlates with erythrosedimentary rates. Then you have haptoglobin, binds extracellular hemoglobin, protects against oxidative stress. Okay. About haptoglobin, so you need to remember when you have anemia, hemolytic anemia, this will decrease. Why? Because haptoglobin is already there in your body. Okay, so don't think that haptoglobin is going to increase in hemolytic because it's going to increase its production. No, it's already there in your body, just floating around, right? And then when you have hemolytic anemia, all the hemoglobin gets leaked out of the cells, and haptoglobin binds to those hemoglobins. So now, from previously, the haptoglobin is going to be decreased, like the free haptoglobins are decreased now, right? So haptoglobins decrease in hemolytic anemia. Okay, so it binds to extracellular hemoglobin, protects against oxidative stress. Hepcidin, this decreases iron absorption by degrading ferroportin and decreasing iron release from macrophages, which leads to anemia of chronic disease. Let's do this one. It's important to understand the whole mechanism of this. So let's see if they have the U-Volt one. Alright, this one works. So you have ferritin coming in, right? Bringing in the stuff. This is the ferroportin. This is the. Okay, this is not English, so I'm going to struggle with that. That's the best quality we can get right now. So iron comes in to the enterocyte, right? So ferritin picks it up, and then you have ferroportin, and this is the macrophage. So how does it get from iron get from here to here? It goes through ferroportin, and then since in blood it gets transferred by transferrin. So transferrin transports the ferrin into this, right? So now say you have infection or something, inflammation or something, right? What does hepcidin do? It inhibits the ferroportin, right? So it doesn't let iron get into the blood basically. So it won't come from the, it will block the ferroportin. Uh, so the iron stays in the cell, or it will block the ferroportin on macrophages, so it stays in macrophages. Okay, this is important when we will talk about it in, I guess, hemat. But just remember these terms: hepcidin, haptoglobin. Don't mix those two up. Know what ferroportin is now, right? It's just a port for ferritin or ferrin. Ferritin is, it binds and sequesters iron to inhibit microbial iron scavenging, right? In chronic disease, this is why we have low iron as well, and we have anemia because of that as well. Okay, so yeah, hepcidin again. Decrease in iron absorption by degrading ferroportin and decreasing iron release from macrophages. So this leads to anemia of chronic disease. Procalcitonin increases in bacterial infection, normal in viral infection though. Okay. Did not know about that, or didn't remember about this one. So procalcitonin, it increases only in bacterial, but it's pretty normal in viral. So I guess this is one more test you can do to figure out if it's bacterial infection or viral infection. Serum amyloid A, prolonged elevation can lead to amyloidosis. So if you have a lot of this, there are chances that this will get settled somewhere, right? And somewhere like these or these, and it causes diseases there or some kind of symptom. So it shouldn't be there. So if it gets picked up in the serum tests, you gotta look out for it. So all of these get upregulated in infection or inflammation, sorry. Okay, and then these ones get in downregulated. So albumin reduction conserves the amino acids for positive reactants. Okay, so albumin is then used up for all of these. Transferrin gets downregulated, internalized by macrophages to sequester iron, because the less of this out there, the less the iron is going to travel anywhere, right? And we don't want iron to be traveling anywhere, because when you have bacterial infection or something, they thrive on iron, I guess. So that's the whole point of this thing and this thing, sequestering iron and to inhibit microbial scavenging. Then you have transthyretin, also called prealbumin. Reduction conserves amino acids for positive reactants. Okay, so transthyretin, we read up there what it was right here. It gets downregulated, also called prealbumin, because it is a gene, right? So it makes albumin, so it gets downregulated. Because this is also reduced, so it doesn't convert amino acids into other stuff. So this can be there for this. So reduction conserves amino acids as well for positive reactants. Know about this. I guess this is really important because I've seen transthyretin come a couple of times. Now erythrocyte sedimentation rate. This is a fun one. RBCs normally remain separated via negative charges. Products of inflammation, for example fibrinogen, coat RBCs, which lead to decrease in negative charge, which causes increase in RBC aggregation. Okay, so what it's saying, when you have inflammation, you have increase in erythrocyte sedimentation rate, right? Why? The mechanism is that the RBCs, product of inflammation, coat the RBCs. So normally RBCs are negatively charged, so now the charge is going to be decreased. And when the charge is, because negative charge on all the RBCs is what repels them, right, from one another. But now if the charge is gone, the RBCs will be attached to each other. Oh, 10 minutes, okay. And aggregate. Denser RBCs aggregates fall at a faster rate within a pipette tube, which causes increase in ESR. Okay. So when it's falling faster, that's an increase in ESR. When it's slower, that's a decrease in ESR. So it's going to be faster when all the RBCs are together because it's heavier, and heavier drowns faster. Often co-tested with CRP, that's C-reactive protein, more specific marker for inflammation. Right. So what increases ESR? Most anemias, infection, inflammation, cancer, renal disease, pregnancy, inflammation like giant cell temporal arteritis, polymyalgia rheumatica, that's the important one. Cancer, metastasis or multiple myeloma, right? And renal disease, end stage or nephrotic syndrome. Decrease in ESR is sickle cell anemia will cause that. Polycythemia, so increase in RBCs, so it dilutes aggregation factors. So then the negative charge won't drop as much, right? So RBCs won't aggregate then, because there's a lot more RBCs for the products of inflammation to coat now rather than a few. Heart failure, microcytosis, and hypofibrinogenemia. Okay, so that this is lower than expected. Okay. Yeah, let's take a break. Acute inflammation. So we just finished ESR and what causes an increase and decrease in it. So now we're going to do acute inflammation. So this will be your transient and early response to injury or infection, characterized by neutrophils in tissue, often with associated edema, rapid onset, seconds to minutes, and short duration, minutes to days. Minutes to days represents a reaction of the innate immune system that is less specific response than chronic inflammation. Okay. So what it's saying is, let's read that again. I got distracted. Transient and early response to injury or infection, characterized by neutrophils in the tissue, often with associated edema, rapid onset. This happens because why? Because neutrophils does what to capillaries? It increases its permeability, right? So when the permeability is increased, there will be leakage of a lot of things, including serum and interstitial fluids and stuff like that, right? So you'll have leakage of fluid, which causes edema. Okay, then you have rapid onset, seconds to minutes, and short duration, which is minutes to days. Represents a reaction of the innate immune system. So innate immune system is everything other than just your T cells, B cells, and there was one more thing, but mainly that. That is so it's less specific response because T cell and B cell go for the antigen itself. They make antibodies against it, but everything else is gonna be looking for the marker. So if it doesn't have MHC1 marker, then natural killer cells is gonna, go after it, kind of like that. So not everything has it, but that is less specific than going for spike protein itself or something like that, right? So less specific response than chronic inflammation. Stimuli: infections, trauma, necrosis, and foreign bodies. Right, so if you have infection or trauma or necrosis or foreign bodies can cause acute inflammation. Mediators, toll-like receptors, arachidonic acid metabolites, neutrophils, eosinophils, antibodies, pre-existing and mast cells, basophils complement, pigment factor, which is factor 12, Infla- inflammasomes, cytoplasmic protein complex that recognizes products of dead cells. Okay, so cytoplasmic protein complex that recognizes products of dead cells, microbial products and crystals, for example, uric acid crystals, that leads to activation of interleukin 1 and inflammatory response. You know what the inflammatory ones are, right? So that's your IL 1, 6, and TNF beta. Uh, sorry, TNF, tumor necrosis factor alpha, I think. Sorry, not beta. Right. Okay, just TNF. So then you also have anti-inflammatory ones. That's going to be your interleukin 10 and tumor growth factor beta, I think. Okay, so an inflammatory response. Components: vascular vasodilation happens, so there will be increased blood flow and stasis and increase in endothelial permeability. This is the one I was talking about. Contraction of endothelial cells, open interendothelial junctions. Cellular, so okay, this is the one I was talking about. Sorry. Extravasation of leukocytes, mainly neutrophils, from post-capillary venules, so accumulation of leukocytes in focus of injury. Leukocyte activation. Okay, so I have no idea what I was talking about. But yeah, okay. To bring cells and proteins to site of injury or infection. Okay, so yeah. To bring cells and proteins to the site of injury and infection. That's the whole point of this mechanism, right? Because you're not going to get injury in the vessel itself, so you need this to happen so the leukocytes can travel outside of the vessels to the site of the injury and infection. Leukocyte extravasation has 4 steps: margination and rolling, adhesion, transmigration, and migration. So we went over that in biochem. Or immuno. Yeah, this one. Okay. So the 4 components. These are your 4 components, right? So margination is it rubbing against the wall. So hemoconcentration and decreased wall shear stress. Right? Okay, so it has integrin on it, low affinity sialylated glycoproteins. Then you have rolling. As the next step. So that's it, just rolling against it, and the receptors get attached to P-selectin and E-selectin, and then you have activation, or activation is just it attaching more and more receptor to more and more receptors and all that stuff, and chemokines lead to integrin activation. Here you have inflamed interstitial tissue, right? So this is where you need it. So that's why this whole process is happening. So it attaches to it. Cytokines induce endothelial expression of selectin. So when there is a damage or infection or something, the cytokines will induce endothelial expression of selectin. So these things will show up more. So it can catch more and more receptors on the neutrophils and all that stuff, right? So and aselectin as well. That's there. Okay, so conformation change to high affinity state. You have integrin ligand ICAM right there, and this is not really important. The important one is PCAM. Welcome to that. Then you have the tight adhesion. So that's the adhesion one, and then you have now the neutrophils have stopped flowing in the blood. They're attached to the endothelial site. And then you have transmigration with the help of PCAM1. transmigration with the help of PCAM1. So, and then this is the migration, right? So, or chemoattractant. It goes into the wherever the site is of infection. So, why is this important? This whole process, it actually is important because of two things. One, you get neutrophilia, increase in neutrophils, apparent neutrophil increase, and corticosteroid use, because corticosteroid use will cause release of neutrophils in the blood, but what it will not let it do is go to the site. So here, the site of infection, it makes it go away from it instead, right? So even the ones that were attached to it, it actually makes that go away from the site of infection. That's one, corticosteroid. The other one is absence of CD18 prevents the formation of functional beta 2 integrins. So the classic buzzwords, or I guess for this LED, is late separation of umbilical cord. That happens in leukocyte adhesion deficiency. It's in the name, so adhesion doesn't happen. So you will have neutrophils. You don't have deficiency of neutrophils. What you have deficiency of is CD18, because that is the one that's responsible for the adhesion. So if you don't have that, adhesion doesn't happen. You still have neutrophils in the thing, so don't be like it's the deficiency of neutrophils. You have it. It's the deficiency of CD18 that prevents this adhesion to happen, right? So that's the most important one. Then there's also LED2, impaired fucosylation of ciliated carbohydrate ligands, preventing selectin binding. And then you have LED3, impaired cytokine signaling, prevents integrin activation. Okay, so that's the whole process of that. So leukocyte extravasation has 4 steps. Migration, rolling, adhesion, transmigration. Transmigration is not happens because of, or is associated with the PCAM1, so remember that. And migration, which is the chemoattractant state. Then you have outcomes. So why is this important? So after all this mechanism, what's going to happen? What you're going to get is resolution and healing, which is because of this and this, because these are, remember, I told you up here, interleukin 10 and TGF beta. It's anti-inflammatory, right? The inflammatory ones are IL-1, 6, and 1, 6, and TNF. So they will recruit IL-8 and IL-12 as well. The inflammatory ones, but these ones are going to be this. So the question would come something in form of that the person had swelling and all this, and it was painful and all that, dolor, tumor, all that stuff. And then after 2 days, the swelling was gone, the pain was gone. So which of these would you find more of in that area? It's going to be these. This is what you're going to find. This is the reason there's resolution and healing. The anti-inflammatory interleukins and this TGF beta, right? Okay, so persistent acute inflammation, IL-8. Abscess, acute inflammation walled off by fibrosis. Okay, so abscess, acute inflammation walled off by fibrosis. Oh, right, okay. So you have an abscess, and after a day or two, macrophages attack. Well, not day or two, but like abscess happens because of macrophages and WBCs, right? So while it's trying to deal with that, on like day 3 and 4, you can start having this fibrous stuff forming. So fibrosis is going to happen, scarring and all that stuff. So interleukin 10 and 8 have a hard time going into it to stop that. That's why abscesses last a lot longer than other inflammation types, because acute inflammation walled off by fibrosis. chronic inflammation, antigen presentation by macrophages and other antigen presenting cells will cause activation of CD4 Th cells, and you get scarring then, right? And this occurs like after 2 weeks, normally, I think. Did they give you that? No. Not here. Okay. So macrophages predominate in the late stage of acute inflammation, peak 2 to 3 days after onset, and influence outcome by secreting cytokines. So normally what you have, how it always works is like even in this and like cellular injury or like myocardial injury and all that stuff, because these two are the ones you're gonna mix up. So if you just follow the pattern, first you have eosinophils showing up, then you'll have the neutrophils. Neutrophils will come call in the macrophages, and then after macrophages you start healing, and you have like uh, fibrosis and stuff happening, and then after fibrosis, after 2 weeks, you get scarring. The timeline is different for cellular and myocardial uh, injury, but the steps are the same. You get eosinophils, then neutrophils, then macrophages, and then the scarring. Okay, so leukocyte extravasation. Extravasation predominantly occurs at postcapillary venules. Okay, we just went over this. It's the same thing. Sure, not wasted your time there, but anyways, step one: migration and rolling. Defective in leukocyte adhesion deficiency type 2. So decrease in cilial Lewis. Okay, so vasculature or stroma. E-selectin, that's the stuff, and that's the P-selectin. So E-selectin, let me do this. So we can follow along. Okay, sorry. Okay, so we have E-selectin. So this is the margination and rolling, right? So E-selectin upregulated by TNF and interleukin 1. We read that here as well. The cytokine induces endothelial expression of selectins. So here they're telling you that as well. The P-selectin, it's released from Whipple palate bodies. So glycan 1 and CD34. Okay. P-selectin is for palate bodies. Leukocytes, you're going to get ciliary Lewis for E-selectin as well, and P-selectin, ciliary Lewis, and L-selectin. Not really sure what the significance of these are, but anyway, they don't ask much about this. These two are the ones that they ask about. So type binding, adhesion, defective in leukocyte adhesion deficiency type 1. This is decrease in CD18 integrin subunit, right? That's the one with the late umbilical cord separation. So normally it separates by the 3rd week, but here it's not. It's going to take longer than that, I guess. Is it 3rd week? I'm not sure. Vasculature stroma, ICAM1. So that's with CD54 and VCAM1, CD106. You don't have to remember these, because I don't. CD11 and 18 integrins. You have LFA1, MAC1. Don't have to remember that. VLA4 integrin. I've never came across anything of such thing. What I have came across is CD11 and 18 integrins and LAD. So this one is for tight binding. If you don't have that, the tight binding is not going to happen. So this thing is not going to attach. You won't have the tight adhesion step, right? Because that's for LED1. Okay. Then you have diapediasis or transmigration. WBC travels between endothelial cells and exits blood vessels. This is important because without this, you won't get leukocytes going into the or to the sites where it's required, like the infection or inflammation site. So this is very important. PCAM1, which is CD31 as well. Uh, I guess remember that. I don't know, but I definitely remember PCAM1, and you get PCAM1 CD31 for that leukocytes. Okay. They interact with that, I guess. Then you have migration. WBC travels through the interstitium to the site of injury and infection, guided by chemotactic signals. Chemotactic factors are C5a, which is also anaphylaxis causing one, the anaphylactotoxin or something like that. So it was C3a and C5a, but C5a is also chemotactic, right? And then you have interleukin 8, LTB4, 5-HETE, kallikreinin, platelet activating factor, and formyl methanol peptide. Basically, you have everything that causes chemotaxis, right? All of these things cause chemotaxis. So various things will show and interact with that. Okay. Again, one more time. Migration and rolling is the first step. It comes and brushes against the border, and then when it brushes against the border, uh, it's only gonna have like a few E-selectin or P-selectin, so it might attach to it but then get ripped off again because it's rolling, and it's gonna roll all the way up where the inflammation is, because the inflammation increases the E-selectin selectin, so that's gonna grab onto the rolling neutrophils, and then that's where it's gonna start interacting with other receptors like ICAM and LFA1, I guess. With LFA1 with the ICAM, sorry. So you get the type binding. After that, you get diapediasis. That's transmigration with the PCAM1, right? So diapediasis. Diapediasis, also known as transmigration. So know this word for transmigration, diapediasis. They might not give you transmigration, they might give you diapediasis. So, okay. So know that. And then you have the migration, uh, going towards where it's needed. Okay, done with that. Okay, chronic inflammation. So we just did acute, now we're going to do chronic. Chronic inflammation is prolonged inflammation characterized by mononuclear infiltration by monophages, or macrophages, lymphocytes, and plasma cells, which leads to simultaneous tissue destruction and repair, including angiogenesis and fibrosis, may be preceded by acute inflammation. The stimuli is persistent infections, for example, tuberculosis, Treponema pallidum, certain fungi, and viruses. These are your type 4 hypersensitivity, which is cell-mediated hypersensitivity. Autoimmune disease, prolonged exposure to toxic agents, for example, silica, and foreign material. So these are all your, chronic inflammation causing reasons. The mediators are macrophages are the dominant cells. Interaction of macrophages and T cells will cause chronic inflammation. The components here were this. The mediators were this as well. Bunch of them. Whereas here, mediators are majority of macrophages. Interaction of macrophage and T cell will cause chronic inflammation. You have Th1 cell secretes interferon gamma, macrophage classical activation. Yeah. Okay, so Th1 secretes interferon gamma, macrophage classical activation, pro-inflammatory, and then you have Th2 cells secreting interleukin 4 and 13, macrophage alternative activation, repair, and anti-inflammatory. Right. Let's go a throwback to that time when we were doing that. Right, so you have Th1 with the interferon gamma making macrophages, but you also gotta remember that it also induces cytotoxic T cells as well, interferon gamma, and then you have Th2 with your interleukin 4, right? CD4 causes Th2. This is your humoral one, so Th2 will then go and stimulate the B cells to make more plasma cells, and right, so B cell by interleukin 4, it goes to B cell activation and IgE production. Okay, the B cells will make different immunoglobulins at the end of it. So that's how you get the humoral immunity from Th2 inter-13. Okay, outcome: scarring, amyloidosis, and neoplastic transformation. For example, chronic hepatitis C infection, which causes chronic inflammation and leads to hepatocellular carcinoma. Remember, it was HB, V, HCV, and HDV that causes hepatocellular carcinoma. The other ones don't. H. pylori infection causes chronic gastritis, and this can lead to gastric adenocarcinoma. So also gotta remember, chronic inflammation of the stomach and esophagus, the Barrett's, will lead to adenocarcinoma. So esophageal adenocarcinoma for Barrett's, and gastric adenocarcinoma for gastritis. They might tell you that there's a malignancy of the stomach and it looks like this, and they'll show you not X-ray, but like a scan of the stomach, and that it's thick. You'll see like rugae, I guess that's what it's called, boundaries and all that stuff, and it's going to look like a brain in the stomach, and that's because it's thickened, and it's thickened because of adenocarcinoma. So they'll give you names of all these cancers, and then you gotta pick adenocarcinoma for the chronic gastritis one. Wound healing. Hold on, let's just get a scan. Right, so I keep doing pictures in here when I should be doing it here. I don't remember which kind of scan it was, so I think it gets picked up in X-rays, but yeah, it was an X-ray. So it was something like this, but there you'll see like a linear pattern here, and you'll figure it out that it's gastritis and or adenocarcinoma. All right, back to this. Wound healing, tissue mediators. So the mediators and the roles. So there's FGF. It stimulates angiogenesis. A lot of things does this. Well, not a lot. At least two things do this. FGF and VEGF. I was talking about this when in oxygen toxicity, right? It also stimulates angiogenesis. There's tumor growth factor beta. This is your anti-inflammatory. So all of this is gonna be your healing ones, right? So you have anti-inflammatory one is there as well. So angiogenesis and fibrosis is caused by TGF beta, VEGF, and then you have platelet-derived growth factors. So secreted by activated platelets and macrophages, induces vascular remodeling and smooth muscle cell migration, stimulates fibroblast growth for collagen synthesis. Then you have your metalloproteases. This causes tissue remodeling. And you have EGF or endothelial growth factor, stimulates cell growth via tyrosine kinases, for example, EGFR and ERB1. I don't know if I have a word for that one. Tyrosine kinase. We'll do it in endo. I'll bring this up in endo. We'll go through the whole path for that. Phase of wound healing, effector cells, and characteristics. Okay, so these are the phases for that. Inflammatory, up to 3 days after wound. You're going to get platelets, neutrophils, macrophages. Clot formation. So remember how I was saying eosinophil comes first, then neutrophils, then macrophages. I guess eosinophil doesn't come here, so I was wrong there. But you get platelets in the first up to 3 days after wound. You get platelets, neutrophils, and macrophages. Then it's characterized by the first 3 days of the wound: clot formation, increase in vessel permeability, and neutrophil migration into the tissue, and macrophage clear debris 2 days later. Okay. Proliferative, day 3 to weeks after wound. Okay. You have fibroblasts, myofibroblasts, endothelial cells, keratinocytes, and macrophages. Deposition of granulation tissue and type 3 collagen, angiogenesis, epithelial cells, epithelial cell proliferation, dissolution of clot, and wound contraction mediated by myofibroblasts. Delayed second phase of wound healing in vitamin C and copper deficiency. Right, so delayed second phase of wound healing. If you have vitamin C or copper deficiency, this stage is gonna be delayed. Because remember, this is required for collagen synthesis in the second step of it. Let's do a throwback to that, because we gotta remember the steps for that. So right there. So the steps were synthesis and hydroxylation. So in hydroxylation is where it requires vitamin C deficiency, right? That's this part right here. It's where the hydroxyl groups attach to the proline, glycine, and lysine. And glycine is the one that's found in abundance, right? And it requires vitamin C for this step. And then you have glycosylation, so sugar is added. Then exocytosis, it's going out. Remember, all of this is happening in ribosomes. Sorry, not ribosomes. It's rough endoplasmic reticulum. Then distribution center to get exocytosis. Then comes the cleavage, pro collagen C and N terminals. So this part is important because this is deficient in Ehlers-Danlos. I don't know how that is spelled, but that. So in this, haha, I can copy paste it. There you go. Oh, I spelled deficient wrong. Okay, so this part is deficient in Ehlers-Danlos. You would think it's this part because that's what I thought, but recently I figured out that it's not this, it's this. So cleavage of procollagen C and N doesn't happen in Ehlers-Danlos. This is important as the pathogenesis of Ehlers-Danlos, and it kind of ties in with the chapter as well because we're doing patho. Okay, so after that, proteolytic processing, cleavage of disulfide-rich terminal regions of procollagen become insoluble troponin, then the assembly and alignment comes, and then comes the cross linkage. Okay, so fibroblasts, we did that, we did type 3 collagen angiogenesis in this, and it's, yeah, deficient in vitamin C. So vitamin C and copper is also needed for that. There was a part I should have gone over, but anyways, if you look at that, you'll find this there. So remodeling 1 week to 6 months after wound, fibroblasts. Type 3 collagen replaced by type 1 collagen, so increase in tensile strength of tissue. Collagenase requires zinc to function. It breaks down type 3 collagen, right? So this is important, type 3 collagen in early wound repair, and then in late wound repair you get type 1 collagen. This is important, they test you on this. So collagenase requires zinc to function, break down type 3 collagen. Zinc deficiency will lead to delayed wound healing. Okay, so we're done with chronic inflammation. Now we're going to do granulomatous inflammation. This is the best kind because it saves us from TB. Pattern of chronic inflammation can be induced by persistent T cell response to certain infections like TB, immune mediated diseases, and foreign bodies. Right? Also in CGD, chronic granulomatous deficiency disease. Sorry. When you have deficiency of catalase. So granulomas wall off a resistant stimulus without completely eradicating or degrading it. So persistent inflammation equals leads to fibrosis and organ damage. Right. Histology. This is what it looks like for TB. So there are two types, right? There's caseating and then non-caseating. So histology, focus on epithelioid cells, activated macrophages with abundant pink cytoplasm, surrounded by lymphocytes and multinucleated giant cells. Formed by fusion of several activated macrophages. There are two types, caseating, associated with central necrosis. It's seen with infections, etiology of, for example, TB and fungal. And then you have non-caseating granulomas. So there is no central necrosis, seen with autoimmune diseases. So for example, sarcoidosis, Crohn's disease. There are also others like berylosis, and I think we just went over one yesterday in micro. It started with B. If someone can recall it, let me know. Okay, let's have a look at what these look like because it's important. So, case creating granulomas. Okay, so see how center is clear mostly. So that's right there. Caseous necrosis. Remember, it was cheese-like. So like that. Okay, and then you have. You want to see central clearing. There will be some kind of cells over there. Right? So that's non-caseating. And this is important to identify because in some of them, like see this one, if you don't know what it looks like, you're not gonna think of all the disease that causes granuloma. But if you know looking at this that it's not like glomerulus or artery, this is a granuloma. Also, the history helps when the question stem and they give you like a lot of things that will give it away. You might not even need to look at a photo, but it's good to know what a granuloma looks like. So look up pictures of that. Uh, but when they're talking about caseating granuloma, it's always going to be TB, not fungal. Okay, non-caseating, a lot of things do that. So no central necrosis seen with autoimmune diseases like sarcoidosis and Crohn's disease. Mechanism is antigen presenting cells present antigen to CD4 Th cells and secrete interleukin 12. Right. Remember, IL-1, 6, and TNF, they both recruit IL-8 and 12. So, mechanism of this is antigen presenting cells present antigen to CD4 Th cells and secrete interleukin 12. So this causes CD4 Th cells differentiate into Th1. That's just this thing. Right, so you have CD4 cells throwing off IL-2, 1 and 2. Sorry, interleukin 12. I'm zoning out. Sorry. So CD4 does IL-12, which recruits Th1. Right. So Th1 then will recruit macrophage and cytotoxic T cells. So Th1 secretes gamma, so macrophage activation. Right. Macrophages increase cytokine secretion, for example, TNF. So this will cause formation of epithelioid macrophages and giant cells. Anti-TNF therapy can cause sequestrating granulomas to break down. This is why it's important to, before giving this, you gotta do PPD tests to, make sure a person doesn't have TB. Because if he has TB and you give anti-TNF therapy, they'll get reactivation of TB. So also another thing, TNF is the one that's responsible for macrophages, but in HIV or AIDS, under 200 CD count of 200, this is deficient. So when TNF is less, you get reactivation of tuberculosis in HIV as well because of that. So anti-TNF therapy can cause sequestering granulomas to break down, which leads to disseminated disease. Always test for latent TB before starting anti-TNF therapy. Associated with hypercalcemia. This is the reason why in caseating granulomas, so they'll tell you that this person has cough, he's losing weight, and there is increase in calcium in his serum. It's because macrophages release vitamin D or something like that. Let's read this. Associated with hypercalcemia due to increase in 1-alpha hydroxylase activity in the activated macrophage. There we go. That's what it is. So this causes increase in 1-alpha hydroxylase activity that converts 25 hydroxylase, which is known as calcidiol, into 125 hydroxylase, or something like that, and which is known as calcitriol, which is the activated form of vitamin D. I remember the numbers. I don't remember what it was for some reason. But what vitamin D does is it increases absorption of calcium from renal tubules and intestine, and also decrease the secretion or excretion of it in the tubules and intestine. It also causes increase in potassium, phosphate, phosphate absorption, and decrease, but not decrease in excretion. It just increases the absorption from intestine, not the renal tubules, I think. So, because this one acts on the receptors which are on intestine majority of the time. It has no action on renal tubules actually, so I don't think it has any effect on what gets excreted or not. But this one definitely increases hypercalcemia. So remember how this whole mechanism works, because that will be tested on. So you have macrophages, which have increased 1-alpha hydroxylase activity, and this is what's required to convert inactive vitamin D to active vitamin D. And vitamin D's action is what? It increases calcium in the blood. Okay. APC antigen, you have interleukin 12 going to TH1. TH1 releases interferon gamma, recruits macrophages. Macrophages then release. You have so it releases TNF, and then you get basically walling off of whatever this is. So when you wall it off, you get granuloma. It consists of lymphocytes, fibroblasts, epithelioid cells. The giant cells are the macrophages. Yeah. So etiologies, infectious ones are bacterial or tuberculosis, leprosy, and then that's the one I was talking about, Bartonella, the one that starts with B. Bartonella henselae, we ignore that word, but Bartonella is the cat scratch disease, because Bart from Simpsons loved to watch Itchy and Scratchy, the cats cartoon, right? And they were cats, so it kind of works out perfectly. If you had a hard time remembering what this was. So this is the cat scratch disease. Stellate necrotizing granulomas. Then you have Listeria monocytogenes, granulomatosis, infantiseptica, and then you have T. pallidum, or tertiary syphilis causes a granuloma as well. In fungus, you have histoplasmosis doing it, so endemic mycosis. Why? Because histoplasmosis hides in the macrophages, right? So histo hides in macrophages. Oh, 2 minutes left. Okay. Then you have parasitic schistosomiasis. So you have S. Mansoni, you have S. hibeptium, you have S. japanicum, and then you have the one that causes cholangiocarcinoma of gallbladder. So cholangitis, cholangiocarcinoma, or something like that. Right, that one was cholangitis sensei or whatever. So all of those will cause granulomas. Catalase positive organisms in chronic granulomatous disease, right? So that's the one I was talking about. Ones that are catalase positive are going to cause this, because you're deficient in catalase as well. So when you're deficient, why this happens is because when you're deficient in catalase, hydrogen peroxide still kills bacteria, right? But then when you're trying to do take care of it, what your catalase is going to convert the H2O2 or hydrogen peroxide into water molecule and oxygen molecule. But then, if the bacteria are catalase positive, what's going to happen? It's going to convert. So let's just do that real quick. So you have oxygen with NADPH oxidase making superoxide. Superoxide dismutase makes hydrogen peroxide. This is pretty useful to for killing off bacteria by itself, but also with myeloperoxidase you get bleach, right? And then to take care of this, you also have catalase, which converts this into non toxic or free radicals, right? But then if a bacteria has catalase itself, then when this goes to attack, or like when it's engulfed or phagocytized, it's going to convert hydrogen peroxide into water molecule and oxygen, so it's going to neutralize it. So then the macrophage can't really kill it off, right? So all it can do is wall it off, right? All it can do is put it in jail, for lack of better words, right? So that's granuloma is just a jail, basically. TB is in jail as well, right? So that's why catalase positive organism in chronic granulomatous disease cause granuloma. Non-infectious, immune-mediated sarcoidosis, Crohn's disease, primary biliary cholangitis, subacute decorn granulomatous thyroiditis. All of these are important. Know them. Mainly this is very important because they ask a lot about this one, and it's really hard to figure out that it's this, because there's not that many things that point towards this, like no buzzwords point towards this. You just need to know what the clinical picture looks like for the biliary cholangitis. Vasculitis, granulomatous with, we'll do that in GIT, by the way. So vasculitis, granulomatosis with polyangiitis, eosinophilic granulomatous with polyangiitis. You have giant cell temporal arteritis. This is the one that causes temporary blindness, but which can lead to permanent blindness if not treated. Takayatsu arteritis. This is the one with I think unstable pulses between two limbs. Then you have foreign bodies, which is berylosis, talcosis, and hypersensitive pneumonitis. So all of these are non-infectious causes of granuloma, right? So if they give you a photo of granuloma and you can figure out that if whether it's caseous or non-caseous, then you can zone in into these or zone in into these for caseous ones. Not these, but like my at least this one and that other one that it does. Right here, fungal and TB, right? All the other ones are going to be your non-caseating ones, but then they also give you history, so you'll figure it out from that. Okay, let's take a break here and come back. Fast and the caspases. So we'll just go through that for real quick. Follicular lymphoma. That's the one that we're talking about, right? Right here. Overexpression of this will cause this. So that's what it's explained. Follicular lymphoma T1418. CD95, that's extrinsic, right? CD95 is extrinsic because it's coming from outside of the cell. Intrinsic would be inside the cell. So from outside, this is the one that causes it. Intrinsic factor is the backs and back. So CD95 death receptor, FAS or facile binds to this. Facile ligand binds to this So this is important in thymic medullary negative selection. We talked about that. Defective FAS and FASL will cause failure of clonal deletion. So then you'll have increased number of self-reacting lymphocytes. And this will cause autoimmune lymphoproliferative syndrome, like SLE. Okay, that's it. And then we're going to talk about this one as well. But we'll come to it. So scar formation, that's where we left off, right? So it occurs when repair cannot be accomplished by cell regeneration alone. Non-regenerated cells, secondary to severe acute and chronic injury, are replaced by connective tissue. 70 to 80% of tensile strength regained at 3 months. Low tensile strength regained thereafter. Excessive or excess TGF beta is associated with aberrant scarring, such as hypertrophic or keloid scars. Okay, so you have hypertrophic and keloid. Keloid ones, the buzzword is claw-like projections, right? Or hands like scratching or whatever. So that's going to be like this, and this usually happens in these areas. And this one's going to be limited to the injury. It's going to be parallel to it, so it's not going to go further than the injury. Confined to borders of the original wound. That's the word. That, like, these are the wordings they're going to use for hypertrophic scar. So collagen synthesis increase, right, in type 3 collagen. Collagen organization is parallel. Extent of scar is confined to border of original wound. Uh, Recurrence is infrequent, and then predisposition is none. And then you have keloid, very much increase in collagen synthesis, type 1 and type 3. That's the early one and the late one. Then you have collagen organization. If you remember, collagen was 4 types that we talked about were scab. So first type is about skin, second one was collagen, third one was about arteries and vessels, and the fourth one was basement membrane found in good pasture. Right. Good pasture and the other one, L-port syndrome, and the kidneys. So extends border, whereas this is confined to the borders. This one extends beyond borders of original wound with claw-like projections, typically on earlobes, face, upper extremities. Recurrence is frequent. Predisposition, increase in incidence in people with darker skin, right? So let's have a look at what that looks like. So see how that is, or that, not that, this. So claw-like projections. You can see that those claws, right? This thing. So these are your keloid scars, and then you have hypertrophic. So these are your hypertrophic scars, right? It doesn't have any projections. Not this. Not this. Not this. This is probably the one, but not this. Not this. But yeah, I don't think that is either. But definitely a photo like this will be given for hypertrophic ones. Or something like this. Yes. Wherever it seems like it's going to be a cut and then it grew and it's confined to the border, or um, it's parallel to the injury, it's going to be hypertrophic. If it has claw-like marks, like those or those, and you know, that's going to be keloid. So in this, they might give you a photo of something like this, so you should know that this is hypertrophic and not keloid. For keloid, they will give you, they might not give you the photo, but they might give you like the description of it, and they'll tell you that it's the scar is now beyond the original site of the wound. Right, so that's going to be your keloid. Neoplasia. I personally don't like this chapter or this topic, uh, but it is very important, especially like everything in this chapter is very important. So let's go through it. Neoplasia and neoplastic progression. Uncontrolled monoclonal proliferation of cells can be benign or malignant. Any neoplastic growth has two components. One, parenchyma, which are neoplastic cells, and supporting stroma, the non-neoplastic, where it's growing. For example, blood vessels and connective tissue. So this is how it occurs, and you need to know these stages as well. So normal cells, you have one normal cell with basal apical polarity, right? So it always starts off in the base, right? And you need to know that like it's not neoplastic yet, even though it's in the base, right? So when they give you cancer and they're going to ask you, where did, how did it start? You're going to think, okay, so the stages go, the deeper you go, uh, the grade increases that way, and the stages increase the deeper it gets, right? First from the skin to the basal membrane to the surrounding tissues to lymph nodes to the multiple lymph nodes, right? That's how it goes. So you're gonna think it's gonna start off on the up here on the epithelial layer, right? But you will get that question wrong then, because it starts off on the basal side, because that's what it has a predilection for. So normal cells with basal have apical polarity. That just means it starts off here and it goes upwards to the apex. See example A, which shows normal cells and spectrum of dysplasia as discussed below. So right now it's just growing. It's not going to be, you can still make out the layers. You can still make out that this is your basement membrane. You can still make out that this is your epithelial cell layer, right? So it hasn't happened yet. So when dysplasia happens, you lose that uniformity and cell shape and size. So that's when this happens. Now you can't tell which layer is the basal layer here and which layer is the epithelial layer, right? So loss of uniformity and cell size and shape, pleomorphism, loss of tissue orientation, nuclear changes, for example, increase in nuclear and cytoplasmic ratio, um, and this is often reversible. Okay, so this this is still reversible. This dysplasia. Then you have carcinoma in situ pre-invasion. 3. Irreversible severe dysplasia. So this wasn't as severe of dysplasia, right? You can still make out the layers. But in severe dysplasia, you can't make out the layers. So irreversible severe dysplasia that involves the entire thickness of epithelium, but does not penetrate the intact basement membrane. Okay, so it's still confined to the basement layer of the membrane. It's not going beyond it. It's just making a little, bump. It's because of the resistance from up here, so it's going downwards. But if there was no resistance here, it wouldn't make the bump, it would just be straight. But it's not going to go below it. and carcinoma in situ. So that's what it means, right? In situ means inside, right? Or in the original place. So that's what it means. So carcinoma in situ is original. Whenever you're talking about carcinoma in situ, it's gonna be about not penetrating the basement membrane. Okay, that's what you're going to be talking about when you're talking about carcinoma in situ. Not only in this, but also in repro cancers and all that stuff, especially the breast ones. Yeah, those ones I hate as well, along with this neoplasm. Uh, Neoplasia. Yeah. Okay. So pre-invasive. It's pre-invasive, so it's not invading your system yet. So this is called pre-invasive. So irreversible severe dysplasia that involves the entire thickness of epithelium but does not penetrate the intact basement membrane. Okay, so now you have invasive carcinoma, number 4. So here the cells have invaded the basement membrane using collagenases and hydrolases. These are your proteineases, right? So you need to know about this. This is how it gets through. So the cells have invaded basement membrane using collagenases and hydrolases, and these are your metalloproteineases. Okay, know these. Cell-cell contacts lost by inactivation of E-cadherin. Right, so E-cadherin is the one that adheres the cells together in the basement membrane. So cell-cell contact is lost by inactivation of E-cadherin. And then you have metastasis. So now it's spread to the distant organs via lymphatics of blood. So this thing has now attached to the epithelium and endothelium of this, right? So now it's invading the vessel itself, and wherever there's like some break or something, it's gonna go inwards, or it will just go right through it. I don't know, and then metastasize. Okay, so you have a normal layer right here. This is the basement membrane right there. You can see that basement membrane going all the way around this line, right? So, and then you have mild dysplasia, right? So here you see the uniformity, right? Uh, these are your squamous cells right here. This is your columnar cells. You can make off of that, right? So here, there's difference of cells here, and then your squamous cells are, you can't make it anymore. Like it's become globoid cells kind of thing, right? Like round cells kind of thing. So it doesn't have a shape anymore. Then so then there's moderate dysplasia. Now yeah, even the cytoplasm is like scant, right? It's scanty, and then you can make out that this, like, even the basement membrane is now losing its shape as well, and the epithelial layer as well. And then in severe dysplasia carcinoma in situ, it's still confined to this line, right? So you won't see it below this line. It's still pink here, and you can see a little purple uh, border over here. So it's not going below the basement membrane, but you see these cells, they don't look anything like the squamous cells it started with, or you can't even make out the basement. So this is your severe dysplasia carcinoma. Tumor nomenclature. You probably already know everything about this, so you don't have to memorize much. Tumor nomenclature is carcinoma implies epithelial origin, whereas sarcoma denotes mesenchymal origin. Both terms generally imply malignancy. Benign tumors are usually well differentiated and well demarcated, with low mitotic activity, no metastasis, and no necrosis. Malignant tumors, cancers, may show poor differentiation, erratic growth, local invasion, metastasis, and it decreases apoptosis. Terms for non-neoplastic malformations include hematomas, disorganized overgrowth of tissue in their native location, for example, Peutz-Jeghers polyps, and choristoma chorios, choristoma, normal tissue in foreign location, for example, gastric tissue located in distal ileum in Meckel diverticulum. Okay. Uh, so for hematomas and the how a polyp can turn into cancer in the intestine, they use the mnemonic AK 53, I think, AK 53 or something like that. So first you lose the APC gene, then you lose the CRAS gene, and then you lose the P53, and that's how it turns into. But we'll do that when we get to it in GIT. I was just trying to recall it. So cell type benign and malignant. Epithelium, adenoma, papilloma, and malignant is adenocarcinoma and papillary carcinoma. Right. Mesenchyme, blood cells, leukemia, lymphoma, blood vessels, hemangioma, and angiosarcoma. You have smooth muscles, glioma, and leiomyoma for when they're malignant. And then you have rhabdomyoma and then rhabdomyosarcoma when they're malignant. Striated muscles are, sorry, we did that. Connective tissue is fibroma, and then it turns into fibrosarcoma. Bone osteoma and osteosarcoma. This one I would say is the important one because I hate bone cancers too. I hate all cancers. I think that's just the general feeling, but I hate reading about it. The osteoma and osteosarcoma. Okay. Fat. You have lipoma and you have liposarcoma, sarcoma when they're malignant, and then you have melanocytes, which are nevus or moles when they're benign and can become malignant. This one is the most important one, and how it happens basically. Uh, you have tumor grades and stages now, so you probably already know this. We kind of went over this. The grade, degree of cell differentiation, tissue of origin resemblance, and mitotic activity on histology. Right? That's what this is what grade is based off of. The degree of cell differentiation and tissue of origin resemblance, and mitotic activity on histology. Ranges from low grade, which is well differentiated. Remember that. The grade is really low and has a high chance of reversing back to the original. So it's low grade when it's well differentiated, when you can differentiate the cells. When they say differentiate, it's like this thing. You can differentiate that this is basement membrane and this is epithelial cells, the squamous cells. So you can differentiate the two. Also, another way is like this is squamous cell and this is of squamous cell as well. It's not of this. Over here, you can't tell if this is from basement membrane or if it's from epithelial origin, right? So this is like really undifferentiated, like you can't differentiate it at all. So, so this would be high grade. This is the low grade one. So ranges from low grade, well differentiated, to high grade, poorly differentiated, or undifferentiated, which is anaplastic. Higher grade often correlates with higher aggressiveness. That's what it means. And this is true for melanoma. Stage and degree of invasion and spread from initial site based on clinical or pathologic findings. So TNM, staging system, importance is from uh, M is the most important, then the N, and then the T. So basically, it's just that T is for tumor that happened, right? And then when it spreads to lymph nodes, and when the lymph node metastasizes to other lymph nodes or other places. Right? So primary tumor size and invasion, then the regional lymph node metastasis, and then the distant metastasis. Stage generally has more prognostic value than grade. For example, a high stage yet low grade tumor is usually worse than a low stage yet high grade tumor. Stage spread determines survival, right? So, a high stage yet low grade. So, high stage would be that it's metastasized, right? Even though it's low grade, it's still worse than a low stage, so it's still in the layer, and even though it's highly undifferentiatable or differentiable cell, right? If it's in the bloodstream, obviously it's going to be worse, right? So low stage yet high grade tumor is less like better has better prognosis because even your radiation therapy and all that, you don't have to go through the whole body. You can just do it at the place where it is, right? If it's low stage. But in high stage, you gotta have like aggressive chemotherapy and radiation therapy at the lymph nodes, all the lymph nodes that were affected. So this is worse because the person has to be willing to fight it out until this whole thing is over. But yeah, so stage spread determines survival. Uh, TNM. Overall, cancer is the bad. Like I hate it and what it does. There are like new things happening recently. There were like, you know, cut through inventions and milestones that they achieved for cancer. So it seems quite promising. Hopefully, it'll get here soon in the trials. Oh, I was trailing off there. Okay. So T, N, and M, blood and or lymphatic vessels spread to other organs and tissues. So they found a marker for cancer. So they're using the marker for therapy, which is only attacking the neoplastic cells and not the normal cells. So that was pretty cool. Hallmark of cancer. Cancer is caused by mostly acquired DNA mutations that affect fundamental cellular processes, for example, growth, DNA repair, and survival. Cancer is, sorry, I was getting zoned out because of cancer. Hallmark of cancer. So, cancer is caused by mostly acquired DNA mutations that affect fundamental cellular processes like the growth or DNA repair or survival. Basically, anything that regulates and anything in the cell cycle, will cause cancer. So, growth signal self sufficiency. Mutations in genes encoding proto-oncogenes. So, these are your uh, over here, it just means cell growth. So, increase in growth factors, autocrine loop. For example, increase in platelet derived growth factor and brain tumors. So, if you have a mutation in that, or growth factor receptors, which are the constitutive signaling, for example, HER2 in breast cancer. I might have that. Just give me a sec. I just want to check something. No, I don't have it. Give me a second. I'll just get it so we can what that means. This showed up in biochem, but we'll do it here too. So how RAS works, right? That's RAS right there. So signaling molecules, and also HER2 is the non-receptor tyrosine kinase 1, right? So, sorry. You have the tyrosine receptors right here, and the tyrosine receptor dimerize and then do the cross phosphorylation, and with the that and with the complex of SOS and GRB2, it attaches to RAS, and then that complex GDP comes in and attaches to that, and then the complex of RAS and GDP separates out of the receptor, and then it goes on to making GTP, and the GTP then goes on to making MAP kinase, right? So this is how HER2 is HER2 or even ERB2 happens, I guess. I forget what the color coding was, but this is the overall thing about this. So signaling molecules, this will show up again, so we'll just put it in the corner right there. Okay, so signaling molecules, and then you have transcription factors, mice, as well. Okay, MYC. Then you have cell cycle regulators, cyclins, and CDK. I mean CDK. Sorry. This was your RB gene ones. So this affects the phosphorylation. I can't see that word. Phosphorylation of the elongation factors and the RB gene, right? So P53 comes in and then activates the CDKs. CDKs activate the P53 RB genes, and then RB genes get phosphorylated. When they're phosphorylated, they're inactivated. So when these are inhibited or they don't show up, then elongation factors don't work without them. We'll do that when it comes. We actually already did it in bio or immuno, I don't remember now. But anyways, anti-growth signal insensitivity, mutations in tumor suppressor gene, again, RB gene. Let's just look at that. I say I haven't uploaded it. This one probably has. So gotta do a recap of this. So let's do that. Okay. So you have this. I'll actually take this out. Okay. So we'll just do a quick review of what this is. Regulation of regulation of cell cycle. Cyclin-dependent kinases constitutively expressed but inactive when not bound to cyclin, right? So when it's not bound to cyclin, the cyclin-dependent kinases, CDK, and this is cyclin. So when it's not attached to it, it's inactive, right? And CDK attaches to P21. So when it's attached to P21, it inhibits this, right? What does it inhibit? P21 inhibits CDK cycling from attaching to RB and elongation factor, causing phosphorylation, I guess. Alright, we'll read that. Cyclin CDK complexes. Cyclins are phase-specific regulatory proteins that activate CDKs when stimulated by growth factors. Okay. So growth factors come in, they tell cyclin to hook up with CDK. The cyclin CDK complex can then phosphorylate other proteins, right? So this is the one that makes RB gene phosphorylated, right? So okay, so CDK and cyclin hook up, and then they tell RB gene to hook up with phosphorylation or phosphate. Sorry. Okay, so this complex must be wait. So cyclin CDK complex can then phosphorylate other proteins, which is RB, to coordinate cell cycle progression. So this needs to be phosphorylated so that it can disinhibit elongation factor. So when it disinhibits elongation factor gets activated and does gene transcription. So then it goes into the cycle goes beyond the gatekeeping over here and into synthesis. So that's how it works. Okay. This part is where I was confused, but that's why we're here right now. Okay. And then tumor suppressors. So this is your P53, right? P53 stimulates P21 induction. Okay, so it does P21 induction, which causes CDK inhibition, right? So when it's attached to CDK, it's inhibited. If it's inhibited, RB gene is not phosphorylated, right? If RB gene is not phosphorylated, it's attached to, it's hooking up. So if it's not hooking with P's, the three P's, it's hooking up with elongation factor, right? So if elongation factor is hooked up with RB, then it's not going to do what it's supposed to, because it's distracted and making out with RB over here. Okay, so you have 53 with P21 induction, CDK inhibition, RB hypophosphorylation, activation, right? Okay. Wait. So RB hypophosphorylation. So this is called activation then? Did I just get the whole thing wrong? G1 to S phase progression inhibition. Mutations in tumor suppressor genes can result in unrestrained cell division. I'm missing something here. If someone can explain this, just turn it on. Growth factors, for example, insulin, PDGF, EPO, EGF, bind tyrosine kinase receptors to transition the cell from G1 to S phase. So growth factors, insulin, PDGF, EPO, bind to tyrosine kinase receptors. That's fine. We already know that. It's just this part that's confusing me. So this only happens when it's connected to RB or not. That's the only thing I'm confused about, because it says RB hypophosphorylation. That means it's not connected to the thing. Okay, so I'll try this again one more time. P53 comes in, does this, because if this doesn't happen, then this doesn't happen. If this doesn't happen, then this goes on to phosphorylating RB genes, right? So what happens when this is not there? If this is not there, then P53 is gonna cell cycle arrest happens. But it's the same thing. I'm sure someone can do a better job at explaining this. Mm-hmm. Okay. Okay. This stuff. Right. Right. So what is this wording then? What does this mean right here? You got stumped there too. The hypophosphorylation. What does that mean? Does that mean this thing? Is that what it is? Uh, wouldn't phosphorylation mean? I think so. Phosphorylation is the attachment of phosphor group to a molecular ion. So then, hypo to a less than normal extent. So or less than fully, right? So it's saying that arbigine doesn't have phosphate group. Then that's what it means. So if arbigine doesn't have phosphate groups, then it's E2F, right? So when does that happen? When this doesn't come in. When does this not come in? Here. Okay. Signals that modulate T cells activation and functions, which leads to decrease in immune response against tumor cells uh, targeted by several cancer immunotherapies. For example, interaction between PD1 on T cell and PDL1 by 2 on tumor cells, or so PDL1 or PDL2 on tumor cells or immune cells in tumor microenvironment. This leads to T cell dysfunction or exhaustion, inhibited by auto inhibited by antibodies against PD1. For example, semiplimab or nivolumab or pembrolizumab. You don't need to know the names, but you need to know the mechanism for this, right? So, or PDL1, for example, etizolizumab or durvalumab or evolumab, right? CTLA4 on T cell outcompetes CD28 for B7 on APCs, which leads to loss of T cell costimulatory signal, inhibited by antibodies against CTLA4, for example, ipilimumab. So they give you, they tell you this is like a drug A. It could be any one of these, and then they explain it that the drug A was given, and then it was inhibiting this thing PD1 to PDL, right? So it's gonna be one of these two groups of drugs. So I have a note on that. Well, let's take a look at that. So that's the tumor cell with PDL1. So it's always the cells coming from outside that has the ligand, right? So, or ligands, um, with the B7 and PDL1, right? So B7 was CD80 and all that stuff, right? And then you have PD1 and CTL4 on this side. So tumor inhibit T cell and evades immune destruction. So when this is attached to this, uh, T cell won't function as it should, and its actual function is to take care of, you know, tumor cell, like take it out. And then so over here we have tumor cell, and then you have anti-PD-1 monoclonal antibodies or anti-CTLA4 antibody, right? So those are these ones which inhibit that. So if it doesn't attach, so then if that attaches to CTL4 or PD-1, that means tumor cells can't attach to it, right? So it can't stop from T cell doing its function. So T cell stays activated and destroys the tumor cell then. So PDL1 programmed death ligand 1 or PD1 programmed cell death protein 1. The binding of PD1 to PDL1 regulated the immune response by inhibiting cytotoxic T cells. Many types of cancers evade immunodeletion by increasing expression of PDL1 on their surface. Monoclonal antibodies against PD1 upregulate the T cell response and promote T cell apoptosis. Okay, so that should make sense to you. So CD28 goes on B cell, and CTLA4 also goes there. You have, so all of, well, at least these two activate T cell activation, right? And then CTL4, if it comes here and attaches to this will inhibit T cell activation, right? So tumor cells, CTL4 ligand is going to do that. So B7 either attaches to this or this. If it attaches to this, it's going to activate this, right? And antigen here tolls T cell receptor with MHC1 would do the same thing as this. So it activates T cell, and then you have PD1 or PDL1 attaching to it and causing deactivation of this. So remember the ligands. The L is on the tumor cells, right? And then you have CD40L, that's on T cell, right? As far as I remember, CD, because these two are the ligands, you gotta remember where's what. Yeah, so T cell has the CD40L and B cell has the CD40. But here the T cell has PD1 and tumor cell has PDL1. Okay. Cancer epidemiology. Okay, so the question is going to be about this. It's going to be like they were doing a research with a tumor cell and they put in T cell, but T cell didn't react, and then they added drug A to it, and then after drug A, there was T cell activation. So what mechanism was this? So it was the, whatever this mechanism is, right? Immune checkpoint interaction, or they'll say, I don't think they give you the names of this, so it's no point, but know the mechanism of how it works. It blocks the answer would be like it blocks the tumor cell so T cell can activate, something like that. Cancer epidemiology. Skin cancer, basal more than squamous, which is way more than melanoma, is the most common cancer, not included below. Cancer incidence. They ask about lung cancer in women. They do that. So males, prostate, lung, and then colon. Similarly, female have breast, lung, and then colon. So prostate are only found on males and breast is only found in females. So that's number one. And then the second most common is lung, and then third most common is colon. You have children with leukemias, CNS, and then neuroblastoma. So lung cancer incidence have decreased in males, but has not changed significantly in females. Why? Because cigarettes were popularized in World War II, right? So people going to war, they were doing a lot more smoking, and uh, they didn't know much about lung cancer back then either. So, and when they came back, that's when there was a rise in lung cancer in females because they picked up the habit too, and then they started having lung cancer because of that. So you will see they'll give you a diagram of cancer, and they'll have the I guess just lung cancer detected in women. So it's going to be a flat line before like the end of World War, and then it's going to start going up, and then it's like decreases a little as it gets closer to present times, right? So it's because there weren't that many women doing cigarettes, but the amount there were, that continued. That's why there was like a low plateau, I think, and then so that's why you have lung cancers in female. So you won't see it before World War II that much rise in lung cancer. Cancer mortality, males, lung, prostate, and uh, colon cancer. So these are the reasons why there's death. So for because of this, lung cancer is still the number one cause of cancer death, right? Prostate is detected, but it can be taken care of. Same thing with breast, right? It can be detected on many people and it gets taken care of. But lung, there's not that much you can do for lung cancer. You can try, but then even radiation will start fibrosing the scarred lung tissues, and you get scarring and all that. So that gets affected as well. Prostate and then colon. Colon is, at a point where it doesn't get detected that much because it's rare. Not in like developed country, at least it does, but like underdeveloped countries, they don't have that system where you have to go get your stool checked or all that stuff. That's why it's the least detected one, but it does cause the most death, like at least at number 3, right? Because there's by the time it gets detected, it's like it's already at stage 3 or stage 4. So that's why this one is really bad. Then you have children with, again, leukemia, CNS, and neuroblastoma. That stays the same. So cancer in second leading cause of death in the United States. Heart disease is first. Common metastasis. Most carcinomas spread via lymphatics. Most sarcomas spread hematogenously. However, for carcinomas root hematogenously, that's follicular thyroid carcinoma, choriocarcinoma, renal cell carcinoma, and hepatocellular carcinoma. This is the easiest one to identify from just the histio slide. Site of metastasis, primary tumor, and nodes, brain. So brain gets it from lungs most of the time. Second common is breast. Third common is melanoma, colon, kidney. Lots of brain metastasis can kill it. Right, so if you have a tumor anywhere here, it can go to the brain. So 50% of brain tumors are from metastasis, commonly seen as multiple well circumscribed tumors at gray white matter junction. That's A and B. Okay. Liver. Liver gets it from colon. This is number 1. So if they say there's a question like a person was found had cancer cells of like colon cancer cells in his lungs. So which one is the first place it was infected, right? So, or actually, I think it was like a carcinoid tumor or something like that. I forget at this point, but because as long as it's metabolized by liver, you won't feel any symptoms, right? So when you start feeling the symptoms, that means it has taken over liver, and now it's spreading through liver as well. uh, so it was something like that. So colon, it always goes to portal uh, liver, right? So that will be the first one, colon, and then the stomach, also the pancreas. Cancer sometimes penetrates liver. Liver and lungs are the most common sites of metastasis after the regional lymph nodes. Okay, they test you on liver though. I don't know about lung. Bone, prostate, and breast, wow, way more common than kidney, thyroid, lung. Okay, so bone metastasis, way more common, more than primary bone tumors. Sorry. So again, just like brain, uh, most of the tumors happening in bone is metastasized tumors. For example, multiple myeloma, predilection for exoskeleton, that's G. Bone metastasis can be lytic. For example, thyroid, kidney, small cell lung cancer. Blastic, for example, prostate, small cell lung cancer. And mixed, for example, breast cancer. Okay. If they want to test you on bone cancer, it's going to be one of two things. One is going to be from prostate, so that's the one they're going to test you on. Or second, they're going to test you on those osteosarcoma and osteoma and all that stuff. They rarely check. It can be lytic as well, the bone cancer, but it's going to be because of like, I don't know, multiple myeloma or something like that. Okay. Oncogenes. Oh, we're almost at the end. I spoke too soon. That's too many pages. Okay, oncogenes. So, gain of function mutations converts proto-oncogene, that's normal gene, to oncogene. So that. So it increases cancer risk. Requires damage to only one allele of a proto-oncogene. Okay, so when it's saying receptor tyrosine kinase, where'd it go? Oh yeah, it means the thing we were looking at. Where's the thing we were looking at? This thing. Okay, so this is receptor tyrosine kinase. Right. What's saying is that uh, damage to only one allele of a proto-oncogene will cause a gain of function mutation. So gain of function mutation is, that just means that whatever it was doing, uh, whatever was like inhibiting, it cannot inhibit it anymore. So it's going to continue doing what it was doing and it cannot be stopped. Okay, so that's why you get increased risk of cancer, because normally this thing is what protects, like it helps cell growth, but it is also controlled as well, right? So like a RB gene would control this, but then if there's a mutation in this, then it's not going to listen to RB gene or P53 or something like that, right? RB, that's this one, sorry, but you get the example. Don't look at the example, just look at the logic. Okay, so elk. I think I had that. Yeah, so elk, HER2, herb, neo, and red. So which ones are those? Let's just highlight those. Elk, herb, HER2, and red. Okay, so these are your tyrosine kinase ones. Okay, cancers. Gene products are receptor tyrosine kinase associated with lung adenocarcinoma. What was ELK? Anaplastic lymphoma kinase. That's what it stands for. Okay, then you have EGFR or ERB1. Same thing, lung adenocarcinoma. You have HER2. That's the easy one. You remember that because of HER2 is known for breast cancer, but also gastric carcinoma. Okay. And then you have RET or RET so for receptor tyrosine kinase, right? So receptor tyrosine kinase. This is for MEN2A and 2B. So you have medullary and papillary thyroid carcinoma and pheochromocytoma. Right. Then we have PCR and ABL. That's the gene, but let's read this for now. Where'd it go? So right there, non-receptor tyrosine kinase, downstream signals phosphorylation tyrosine kinase that is bound to intracellular JAK. So it activates JAK-STAT pathway and activation of transcription factors that way. So these are your BCR, ABL, and JAK2. Okay. So done with that. So BCR and JAK2, they both do non-receptor tyrosine kinase and non-receptor tyrosine kinase over here. CML, ALL for BCR and ABL. It's 3 letters and 3 letters, right? So BCR and ABL. So 3 letters again and 3 letters again here. RET is easy to remember. HER2 is easy to remember. ALK has L in it. L for lung adenocarcinoma. So AL. So L and A. So that's your lung, and adenocarcinoma go backwards. EGFR is usually endothelial growth factor. Just remember there's endothelial lining in your lungs, right? So that gets changed with oxygen and like other toxicities. So you get lung adenocarcinoma over there. HER2, already went over that. Don't forget gastric carcinomas is HER2. RET, that's the easy one. 3 letters. CML, ALL, and non-tyrosine kinase are only done with, since it uses JAK-STAT pathway. JAK2 is the oncogene there, and the oncogene BCR, APL. So anywhere here, if any one allele for these is affected, then it's gonna have a gain of function mutation. Okay, so let's do the ones we know. So we know BRAF, serine threonine kinase, that's what it is, right? You have melanoma, non-Hodgkin lymphoma, colorectal carcinoma, papillary thyroid carcinoma, and hairy cell leukemia. I would do one, but even it wouldn't be appropriate for this. And yeah, just make up a mnemonic for that, I guess, for BRAF. Because BRAF sounds like, yo, bro, what the fuck, right? And then you can just plug these in after that. c-KIT is cytokine receptor, CD117, gastrointestinal stromal tumor, and mastocytosis. Okay. stromal tumor and mastocytosis. This is C mice or N mice, so that's MYCC or MYCN. These are both your transcription factors. So C mice is known for Burkitt's. Remember, Burkitt was with. We read this when we were reading Epstein-Barr virus, and CD21. So this is all related to that. And then you have N mice transcription factor, and it's for neoblastoma. So neuroblastoma there. CRAS, you should know CRAS. We did that too, right? So CRAS is part of this, I guess. KRAS, right? So it uses the RAS GTPase. So that's your RAS GTP right there. So it uses that pathway, I guess. So CRAS, right? So you have colorectal, lung, and pancreatic cancer. For this, I made a little drawing that just helps me remember. I don't know if it's gonna show here. So I just did. What did I do? So I did K. And then I did R. And then I did A like this. And then I had a S. So it looks like a face, right? And it's just at the lungs, the pancreas, and the colon. Alright, so that's what it looks like, my face that I made in the book. So that's how you know it's lung. Pancreas is in the middle right there. And then you have colon or colorectal cancer right there. That's how I remembered it. It probably won't help you, but it's there if you need it. Anyways, okay, then you have BCL2, anti-apoptotic molecule. You remember this, right? It's be clever and live. So this is the one that prevents apoptosis by its making the cell membrane or mitochondrial membrane impermeable to leakage of cytochrome C. Right, so follicular and diffuse large B cell lymphomas. Right, went over that too, but if you want to see it again, it was this thing. Sorry, this. Never mind. That's just the follicular, not diffuse large B cell though. But anyways, so again, CD95 death receptor is FAS. It binds to fast cell. So this defect causes failure of clonal deletion. So there will be increased number of self-reacting lymphocytes, autoimmune lymphoproliferative syndrome like B cell lymphoma as well, I guess. But this one's easy to remember. CRAS, it's like a face, but on your body. So 2 lungs, 1 pancreas, and then you have 1 colon. Mice N for neuroblastoma. Mice C for Burkitt's. c-KIT is in the name, cytokine receptors, right? Is for gastrointestinal stromal tumor or GIST. Okay. And mastocytosis. BRAF is like, bruh, what the fuck, man? I got a skin cancer. Oh yeah, I got hairy cell leukemia, man. I got hair all over me. Something like that. I don't know who these guys are standing around talking about their BRAF cancer. But yeah. JAK2 and BCR-ABL are non-receptor tyrosine kinase. BCR-ABL is 3-letter ones, so CML and ALL. Then you have JAK2 you doing the myeloproliferative neoplasms. You remember red because it's in men 2A and B, so that covers the medullary and thyroid. But here we have papillary as well, and then you have pheochromocytoma as well. HER2 is for breast and gastric carcinoma. EGFR is endothelium lining in the lung, so that turns into adenocarcinoma, so lung adenocarcinoma. ELK has LA in it, so that's lung adenocarcinoma. These ones use receptor tyrosine kinase pathway. Okay, so, and this is gain of function mutation, which converts the proto-oncogene to oncogene. So there's increase in cancer risk. Requires damage to only one allele of a proto-oncogene. So done with that. Try your best to remember or memorize that. This is very important. It's gonna come throughout the whole UWorld. All of this and all of this as well. So now we're gonna do tumor suppressor genes, loss of function, which leads to increase in cancer risk. Both two alleles of a tumor suppressor gene must be lost for expression of the disease. The Condonson two-hit hypothesis, right? So if you lose only one, it's okay. You still have the other one to take care of all the functions. It's like captain and co-captain. So co-captain can handle it when the captain falls asleep, kind of thing. Okay, so you have gene product, and associated condition. You have APC, right? So remember I talked about AK53. So the A is for APC. So this is what you lose, and it goes from being a irregulated cell growth to being a polyp or something like that, adenocarcinoma. Actually, let me just bring that up here. So okay, that's not there. Okay, so it's somewhere here. Yeah, right there. So this thing right here. Okay, so APC is this thing right here, chromosomal instability pathway. You have a normal colon, and then you have loss of APC. So you have decreased intracellular adhesion, and also an increase in proliferation, right? So negative regulator of B-catenin and WNT pathway. You end up with colorectal cancer associated with FAP. This is carcinoma, but to get to that, you also gotta lose APC and have a KRAS mutation, right? So KRAS, we met that person here, right? So the face on the body. Okay, so lungs, A for pancreas and S for colon. So when you lose the APC, you get decrease in intracellular adhesion, so it's not adherent to just the cell. So now it can adhere to cell on cell as well. So there will be a proliferation like that, and then you get KRAS mutation. This is a gain of function, right? So what it was doing, it's just gonna keep happening now. Unregulated intracellular signaling, so then it turns into an adenoma. When you have adenoma and you lose the tumor suppressor genes, we're gonna come to that, RB and TP53, sorry. So that's your P53 activates 21G1 to S phase, right? That will increase the tumor genesis, and then you get this carcinoma. So this whole thing has an acronym called AK. So A for APC, K for KRAS, 53 for TP53. Okay. So colorectal cancer, associated with fat. You have BRCA1 gene and BRCA2 gene. Sorry, not BRCA. BRCA1 and BRCA2. BRCA1 and BRCA2 proteins. You should know this already, because it's breast, right? That's the most popular one that everyone knows about. And then you have ovarian, prostate, and pancreatic cancer as well. So CA for cancer, BR for breast, and then in the middle you also have ovarian, prostate, because breast is usually associated with ovaries. So you have ovarian cancer, and a man who has if he has breast, then he's gonna get cancer in prostate too, I guess, and pancreatic as well. These three are, you gotta just remember that. Breast pop cancers, pop as in prostate, ovaries, and pancreatic. Okay, moving on. CDKN2A. This is P16. It blocks the G1 from going on to the S phase, so it can be many cancers. For example, melanoma can do this. Lungs and pancreatic cancers can have, a loss of function of CDKN2A. Sorry. DCC, deleted in colorectal cancer. Colorectal cancer. That's kind of easy to remember. CC, so colorectal cancer is the only acronym that comes to mind for that. And then you have SMAD4 or DPC4, so it's deleted in pancreatic cancer. Is this a new one? Because I remember this one. Just checking. No, it's there. Okay, so DPC is deleted in pancreatic cancer, or SMAD, pancreatic cancer and colon cancer. I haven't seen them any questions asking about these three, so it would be safe to say that they don't get asked much. Okay. You have MEN1. MEN1 is associated with multiple endocrine neoplasia 1. Yeah, let's go look at that one as well. So, that. Okay, so right there. So MEN1 has pituitary, pancreas, and parathyroid cancer, right? So question for this would come like, there's a history of cancer in this patient. So the mother died of pituitary cancer and the dad had a pancreatic cancer. Along with these two, what other cancers should this person also be screened for? So they should be screened for parathyroid as well, because these cancers are, associated with MEN1. So, and then there's MEN2 then, which is parathyroid, thyroid, and pheochromocytoma. And then you have MEN2B, which is medullary thyroid carcinoma, and then pheochromocytoma, and then mucosal neuromas. But for the one that we did, MEN2, B and A, it also consists of papillary thyroid carcinoma, not just medullary. We'll look at that when we go back. But this one you can remember by, like, the first one is 3 P's, so pituitary, pancreas, parathyroid. Then you have 2 P's, that's parathyroid and pheochromocytoma, along with thyroid. And then you have just 1 P, pheochromocytoma, and then thyroid and mucosal neuromas. Okay. Okay, let's get through this. So men1, again, 3 P's, right? And then you have neurofibromatosis type 1. Neurofibromins, this is RAS GTP is activating protein as well, right? We looked at that. So neurofibromatosis type 1. Then you have NF2. This is Merlin Schwannoman protein. That's neurofibromatosis type 2. Then you have, so it's in the name, like EA Sports, it's in the name. NF2, neurofibromatosis 2. Okay, P10, negative regulator of PI3K AKT pathway. So P10 is also in the name. So you have prostate for P. T gives you breast. EN gives you endometrial cancer. When you're talking about anything like ovarian or endometrium, it's going to be associated with breast, right? That's why many breast cancers patients also get screened for cancer in the uterus and ovarian and all that stuff. Also, the chances for cervical cancer increases in breast cancer. Okay, so I'm trailing off again. 10 minutes. RB1 inhibits elongation factor, so it blocks the G1 to S going on to the S phase. Okay, so retinoblastoma and osteosarcoma. Then you have TP53. P53 activates P21, blocks G1 to S phase. Most cancers leave Rimini, Sebla, which is multiple malignancies at early age. So that's sarcoma, breast or brain, and then you have lung or leukemia, and adrenal glands. So this one is really important to remember. This is, I think, asked the most, and not that it's asked the most, just really hard to figure out from the question, because they will tell you that this person has a history of breast cancer and mother, and dad died of lung cancer, sister probably had like adrenal gland or had some kind of issues with hormones, something like that, and then you gotta figure out that this is Sebla, which is Leaf-Rumini syndrome, right? So you gotta know this one, and it uses TP53. Tuberous sclerosis, it's in the name. TSC1, it uses hemartin protein. Then you have tuberous sclerosis 2, 2 for tuberin. So 1 uses hemartin and 2 uses tuberin. Then 1 Hippolinda, it's in the name as well. Inhibits hypoxia inducible factor 1A. We'll learn about this one in renal, I think. Same thing with this. Wilms tumor, so that's Wilms tumor, nephroblastoma. Urogenital development transcription factor. Again, quick review. APC uses APC is colorectal. We went over why APC and what it does. BRCA, that's breast cancer, and between breast also associated with ovarian and prostate. And you had one more piece because breast pop cancer, so that was pancreatic. CDKN, that is CDKN, DCC, and SMAD. I'm not gonna remember that, so I'm just gonna skip over that one. MEN1 you need to know because it's associated with endocrine group of cancers, which was pituitary, parathyroid, and another P, pancreas, I think. Then you have NF1, that's neurofibromatosis 1 and 2. P10, the P is for prostate, T is for breast, and EN was for endometrial cancer. Yeah. And then you have RB1. This is for retinoblastoma. That's the one you're going to remember. But you also gotta remember that it's also osteosarcoma and bone cancer, right? So If they find RB gene and the eyes are fine, it's going to be because they are having a bone cancer. Then you have TP53, leufemia. Gotta remember SEBLA. Sarcoma, breast, brain, lung, leukemia, adrenal gland. Also gotta remember the gene product for this. So it's P53 activates 21. It blocks the G12S phase. TSC was tuberculosis. Tuberculosis. One is Hemerton. Two is tuberose. Von Hippel-Lindau was that or VHL, and Wilms tumor was that. Uh, Wilms tumor urogenital development transcription factor 1 Hippel-Lindau is inhibits hypoxia inducible factor 1A. All right. And now we're going to do carcinogens. Toxin exposure, organ, and impact. Aflatoxins or aspergillus. Exposure, stored grains and nuts. Organ is liver, and impact is hepatocellular carcinoma. Okay. Then we have alkylating. So for this, I think it's there's some grains stored in a silo, and then a person works with that stuff. And they come with like increase in ESTs or ALTs. You know, so chances are they got aspergillus or aflatoxins because they're carcinogens. So he has hepatocellular carcinoma. Alkylating agents, oncology, chemotherapy. Organ is blood, and impact is leukemia or lymphoma. Aromatic amines, for example, benzidine or naphthylamine. So exposure is textile industry, dyes, tobacco smoke to naphthylamine. And organs is bladder, and you can get transitional cell carcinoma. Arsenic herbicide is a herbicide. So vineyard workers, smelting, wood preservation. And then organ is liver, lung, skin. Impact is hepatic angiosarcoma, lung cancer, squamous cell carcinoma. Asbestos, we know this one. Old roofing material, shipyard workers, old building, right? Or old houses, anything. They might have this. So, organ, lung. Impact is bronchogenic carcinoma, more common than mesothelioma. Tobacco smoke is going to be everything: bladder, cervix, esophagus, kidney, larynx, lung, oropharynx, and pancreas. For pancreas, it causes pancreatic adenocarcinoma. Oropharynx, squamous cell carcinoma. For lungs, it's squamous cell and small cell carcinoma. So Barrett's would be, remember, Barrett's is different. Barrett's is adenocarcinoma, whereas oropharynx from tobacco smoke, it's squamous cell carcinoma. And it gets confusing because tobacco smoke, that also means tobacco, right? So when you smoke, you tend to have GERD as well, and the GERD is going to cause Barrett's, but then smoke causes squamous cell carcinoma. So you gotta then check out what the histology is showing. Squamous cell is going to show you somoma bodies, I think, right? No, keratin pearl then? Was it keratin pearl? But it has a identifying feature. Let me just check that. Yeah, so keratin pearl. That's what you see. This thing right here. Right, so it's from keratinization. Okay. So that thing. Yeah, so you'll have an identifying feature for that. So So smoking causes GERD, or gastric reflux disease, esophageal reflux disease, and GERD can cause Barrett's, but like here it says tobacco smoke can cause squamous cell carcinoma and oropharynx as well. Right. So lung, squamous cell and small cell carcinoma, larynx, squamous cell carcinoma, uh, esophagus. Okay, this is what I was talking about. Sorry, not oropharynx, but like esophagus, squamous cell carcinoma, and or adenocarcinoma. So anything above esophagus, it's gonna be squamous cell. Don't worry about adeno over there. Sorry, larynx or pharynx, right? Or oropharynx. But when it gets to esophagus, you gotta differentiate between the two. Cervix is squamous cell carcinoma, and bladder is transitional cell carcinoma. Ethanol will cause squamous cell carcinoma as well in esophagus, but then again, ethanol also causes GERD, I think. So, your liver, hepatocellular carcinoma, and breast is breast cancer. Uh, so I'm ethanol can cause breast cancer in breast, and hepatocellular cancer in liver, and squamous cell cancer in esophagus, which is pretty cool because you're not going to get hepatocellular carcinoma in esophagus, right? That's pretty cool. It's easier for us to remember it that way. Ionizing radiation. I'm losing my mind now. Ionizing radiation, blood, leukemia, thyroid, papillary thyroid carcinoma. We went over that already, and we went over these two as well. Papillary thyroid carcinoma has a pretty distinctive feature as well, and it has a mnemonic too, because this one has sumoma bodies, and it has the orphan eyes in it. So those kind of things, that's called the orphan eyes. We'll do that when we get to it. Leave it for now. Nickel, chromium, beryllium, and silica. Occupational exposure, lung and lung cancer. Right. We'll do that in recipe. Nitrosamine. We'll do this in GIT, but normally smoked foods is what causes gastric cancer in stomach. Again, gastric cancer in stomach, which is easy to remember because you're not going to get gastric cancer in like the lungs. You can if it's metastasized, but for that it's gonna have to go through the liver as well. So, radon. Radon is the number 2 leading cause of death. So, byproduct of uranium decay accumulates in basement. So this is used to, I guess, kill rats or cockroaches or something like that. So people put it and then they forget about it because they put it in a place where they don't have to look at it. So then it just stays there in the basements or under the fridge or something like that. And then byproduct of uranium decay accumulates right in that area, and then it seeps down to the basement. So if you have people living in basement, they're gonna have high risk of lung cancer. So in lung again, second leading cause after tobacco smoke. And then you have vinyl chloride. You should know about this because they do ask you about this one. Or vinyl chloride. So used to make PVC pipes. It affects liver and hepatic angiosarcoma. Right. Since it's liver, it's not going to be colorectal angiosarcoma. It's going to be hepatic angiosarcoma. Okay. I think these are pretty easy to remember after you start doing questions about them. So, oncogenic microbes, EBV, is associated with Burkitt's lymphoma, Hodgkin's lymphoma, nasopharyngeal carcinoma, primary CNS lymphoma, in immunocompromised patients. You have HPV and HCV causing hepatocellular carcinoma. Also, HDV does this too, but it can't on its own. It has to be with this. So. Then you have HHV8. So that's your Kaposi sarcoma, right? So herpes simplex virus 8. Um, then you have human papillomavirus, usually types 16 and 18, causing cervical and penile anal carcinoma, head and neck cancer. Then you have H. pylori, gastric. So look up condylomata. Which one was it? There's acuminata and there's this other one that's associated with this. Lata, I think. Acuminata. No. Condylomata lata. So I think that's the one with this. So look up what that looks like. I don't want to do it on this because it's gross. But they will describe that in words. So find a photo that's described in words so you remember what it is. So cervical and penile anal carcinoma, head and neck cancer, H. pylori, gastric adenocarcinoma and malt lymphoma, HTLV1. This is associated with adult T cell leukemia and lymphoma. This is a retrovirus. It was along with HIV as well, and this one also has reverse transcriptase. Then you have liver fluke. This is the one that causes the cholangiocarcinoma, right? Then you have hematobium, so that's squamous cell bladder cancer. Okay, so S for squamous cell, and then C for cholangiocarcinoma. So remember that they will tell you that it's a liver fluke, and then this patient has difficulty after eating something fatty or something, and so it's going to be this one then. Serum tumor markers. Tumor markers should not be used as the primary tool for cancer diagnosis or screening. They may be used to monitor tumor recurrence and response to therapy, but definitive diagnosis made via biopsy. Some can be associated with non-neoplastic conditions as well. So you have alkaline phosphatase, right? Important association is metastasis to bone or liver, Paget disease of bone, and seminoma or PLEP. Okay. Exclude hepatic origin by checking LFTs and GGT levels. So that's gamma glutamyl transferase levels, right? So alkaline phosphatase, it can be because of bone and liver causes. So how do you differentiate between the two? You exclude hepatic origin by checking LFTs and gamma glutamyl transferase levels. So that's how you differentiate between the two. They'll do this in GIT as well. Again, alpha fetoprotein, hepatocellular carcinoma, endodermal sinus, yolk sac tumor, mixed germ cell tumor, ataxia telangiectasia, and neural tube defect. Right, this is the one with decrease in immunoglobulin A, G, and E. Right, so neural tube defects, normally made by fetus, transiently elevated in pregnancy, high levels associated with neural tube and abdominal wall defects, low level associated with Down syndrome. We'll do this like in repro as well. So, but this is important, so know this for sure. That does get tested on. So it transiently elevated in pregnancy, It's normally made in fetus. High levels associated with neural tube and abdominal wall defects. Low level are associated with Down syndrome. Down syndrome one is the most important one there. Then you have human chorionic gonadotropin hormone. So this is HCG. Uh, it's associated with hydatid form moles and choriocarcinoma, and uh, then you have to figure out if it's complete or partial, right? We'll do that in repro. Gestational trophoblastic disease, testicular cancer, mixed germ cell tumor, produced by syncytial trophoblast of the placenta. Then you have CA15-3 and CA2729. I just think of it like, okay, so it's a person who's 15-year-old, 27, 29-year-old that can have breast cancer. And then for 19, this one is easier because when you pronounce pancreatic, you pronounce it pancreatic. Right, so it's pancreatic because it's all nines with this one. At that point, when you see 19 and 9, you're just gonna remember that it's pancreatic adenocarcinoma, right? It's A for carcinoma. And then you have 125. So I just remember, okay, so a person who had 2 ovaries now has 5. That's how I remember that. So it's epithelial ovarian cancer. It's silly, but it works for me. Then you have calcitonin. So I'll just put that for that one. One person with 2 ovaries now has 5. So they have ovarian cancer. Calcitonin, medullary thyroid carcinoma alone and in men 2A and men 2B. So calcitonin. And then you have CEA. So this one is for colorectal carcinoma. Then embryonic. No, wait. E was for breast, I think. So EA, I remember it for. So let's write that. So C is for colorectal, and then there was so there's pancreatic cancer as well, and then there's also breast cancer as well. So that takes care of at least 3 of them, right? The most common ones are like it's mostly associated with colorectal and pancreatic cancer, but minor association also with gastric, breast, and medullary thyroid carcinoma. You need to know this as well because they do sometimes bring it up in over here, this marker. They'll tell you that they'll tell you somehow that it's not colorectal and it's pancreatic function test was all normal. So then you're gonna think, okay, then what else was it? CEA. Okay, so it is associated with breast. It's associated with gastric. I'm just trying to think how I can fit CEA and gastric. I can't. Okay, so then you have medullary thyroid carcinoma as well. Right. This one is in men, so you can think of it like that. That it's in small e. Maybe like that. Men 1. Take that away. But then it doesn't help. So this mean 1. It's right. So that can maybe you can recall it with that. So CEA, colorectal, pancreatic, the most important ones, but also remember breast, gastric, and from men you'll remember medullary thyroid carcinoma. But it's actually in men too, not one. My bad. Meant to be A and B, right? So, chromogranin, neuroendocrine tumors. We'll do this in endo. LDH is testicular germ cell tumor, ovarian dysgerminoma. Other cancers can be associated as indicator of turbin burden. Uh, this is easy one to remember, and it is if you have increase of this, it's gonna be at least one of these. So tumor germ cell tumors, ovarian germinoma, but then also there are others like bone cancers. I think also do this. So we'll come across it somewhere and we'll figure it out there. Neuron specific analyses, neuron endocrine tumors, for example, small cell lung cancer, carcinoid tumor, and neuroblastoma. And then we have PSA. PSA is, we should know that already because it's the only prostate specific antigen test we do for prostate cancer. So prostate specific antigen also elevated in BPH. Yeah, that's the one we check for. And prostatitis. So questionable risk benefit for screening, marker for recurrence after treatment. Okay, so important immunohistological stains. Determine primary site of origin for metastatic tumor and characterize tumors that are difficult to classify, can have prognostic and predictive values. Okay, let's do the ones that I already know about. So I know S is for Schwann, so S100. It's for neural crest cells because it's schwannoma, right? That's the tumor in the between brainstem and medulla, I think, where the origin of vestibular cochlear nerve is, or seventh, yeah, it's between seventh and eighth nerve, basically, somewhere there. And then you have melanoma, and then you have Langerhans cells, histiocytes, right? So these are all about neural cell crest cells. Sorry. Okay, so done with that. We have PSA. We did that. Prostatic epithelium, prostate cancer. Right. Then we do GFAT. That's also neuroglia this time. This is gonna be astrocytes, Schwann cells, and oligodendrocytes. So that's with astrocytoma and glioblastoma. Okay. So Desmond we should know, I guess, because it's the muscle tumor cell. So you do it for rhabdomyosarcoma. So if they say there's increase in Desmond, you're gonna think, okay, so there's something wrong with the muscles, right? Rhabdomyosarcoma. Then you have cytokeratin, so epithelial cells, epithelial tumor, for example, squamous cell carcinoma. Okay, so cytokeratin, that's an easy one to remember. Keratin is in the skin. So then epithelial tumor, so squamous cell carcinoma. Squamous cell carcinoma is the one with the classic keratin pearl depiction, right? Then you have chromogranin and synaptophysin. This is very important to know because that's how you differentiate between other lung cancers to small cell carcinoma of the lung. Then you have carcinoid tumor, the one with the serotonin, I think, or histamine, serotonin probably, and neuroblastoma. We'll do that too. So this is for neuroendocrine cells. Neurofilament neurons, that's neuron tumors, neuroblastoma. We have TRAP for titrate. This is a really easy one to remember because, okay, it stands for tartrate resistant acid phosphatase. But why? Because think of a fly, you know, getting trapped in a man's chest that is hairy from 1980s or something, right? So hairy cell leukemia has trapped the fly. I don't know why a fly, but you can think of something else that gets trapped in a chest hair. But hairy cell leukemia. TRAP is for tartrate resistant acid phosphatase. And last one is vimentin. So that is for mesenchymal tissue, for example, fibroblasts, endothelial cells, and macrophages. Mesenchymal tumors, for example, sarcoma, but also many other tumors, for example, endometrial carcinoma, renal cell carcinoma, and meningioma. All of these do come up. I guess these are the only ones that do come up, so it's not that hard. Just go over it one more time if you need to. But we will go over all of these one more time in their respective chapters. P glycoproteins, ATP dependent efflux pump, also called multi-drug resistance protein 1, MDR1, classically seen in adrenocortical carcinoma, but also expressed by other cancer cells. For example, colon, liver, used to pump out toxins, including chemotherapeutic agents. One mechanism of decreased responsiveness or resistance to chemotherapy over time. There was a question about this, and I didn't get it at the time because I didn't remember this. So let's read that again. ATP dependent efflux pump, also called multi-drug resistance protein 1, MDR1, right? So this is the one that causes multi-drug resistance. Efflux pump also, okay. Classically seen in adrenocortical carcinoma, but also expressed by other cancer cells as well. For example, colon and liver. It's used to pump out toxins, including chemotherapeutic agents. So it pumps out toxins out of the cells, including chemotherapeutic agents. So one mechanism of decreased responsiveness or resistance to chemotherapy over time. So at that point, okay. Yeah, I'll figure it out when a question comes for this. Sumoma bodies, laminated concentric spherules with dystrophic calcification. So sumoma's bodies are seen in. Remember this acronym. This is the easiest way to remember this, or another easiest way of remembering this is if you see sumoma bodies and you know how to identify it, then that's even better. But then when you come to remember which one causes this, then you're going to be in trouble because you didn't remember this. So let's do that. Papillary carcinoma of thyroid. Okay. Then you have somatostatinoma, right? That's the one where that's the hormone that inhibits everything. Somatostatin. So this is about that. Then you have adrenals, calcifying fibrinous pseudotumor. So we'll do this one in endo. We'll do this endo as well. We'll do this one in endo as well. Meningioma, malignant mesothelioma, ovarian serous carcinoma, prolactinoma, and serous endometrial carcinoma. We should know what it looks like, so let's look it up. So that's the first one that showed up, but yeah, this is sumoma bodies. Know how to differentiate this with keratin pearl. Okay, I'll just try to see if they have it. So this is sumoma body, and that's a keratin pearl. So this one looks like an onion, and this one doesn't. So if you see a block that looks like a pearl, that's keratin pearl, that's squamous cell carcinoma, right? And then, yeah, okay. Again, papillary carcinoma of thyroid, P for that, and S is for somatostatinoma. A is for adrenals, calcifying fibrous pseudotumor. M is for meningioma. Another M is for malignant mesothelioma. O is for ovarian serous carcinoma. This one is easier to remember. Like you have to remember it for this because they'll have a lung cancer. Then you're gonna have to differentiate if what was it? This one, where'd it go? This one, asbestos. So if asbestos caused bronchiogenic carcinoma or mesothelioma, so they'll give you like a photo, and if there is a sumoma body there, then it's gonna be mesothelioma, right? So that's why you need to know what that looks like for that. Ovarian serous carcinoma, prolactinoma, milk, and then serous endometrial carcinoma. Then we have cachexia, that's just feeling weak when you're sick, right? So you're gonna have weight loss, muscle atrophy, and fatigue that occurs in chronic disease. For example, cancer, AIDS, heart failure, and COPD. It's mediated by tumor necrosis factor alpha and interferon gamma. Uh, Basically, the inflammatory ones, uh, these three, and then also interferon gamma. Okay. Paraneoplastic syndrome. This is one of the most important pages in the whole book, and we'll go through it. Okay. So paraneoplastic syndromes: manifestation, description, mechanism, and most commonly associated tumors. Musculoskeletal and cutaneous ones. So you have dermatomyositis, progressive proximal muscle weakness, papules, and heliotrope rash. That's antisynthes as well. It's associated with adenocarcinoma and especially ovarian, I guess. Okay. Then you have acanthosis nigricans. That's hyperpigmented velvety plaques and axilla and neck. That's gastric adenocarcinoma and other visceral malignancies. Sign of lesser trillet. That's for uh, stomach cancer, colon cancer. Sudden onset of multiple seborrheic keratosis. This is the most important sign for this one, GI adenocarcinoma. So remember that in gastrointestinal adenocarcinoma, you get like a person will sleep and the next day they or like in 2 to 3 days they start seeing these pop up, and by the end of the week they're like their whole body is full of this, like at least the trunk. uh, that means they have adenocarcinoma or stomach cancer. That's going to be the like gastric cancer is going to be the option, I guess. And other visceral malignancies. Hypertrophic osteoarthropathy. They might also tell you that the person has Werchow or Werchow nodule. That's the lymph node on the subclavicular lymph node or supraclavicular lymph node on the left side. And that's going to be the thing. Because on the left side is the one that drains the abdomen, diaphragm, and all that stuff. The right one only goes up to the abdomen but doesn't do the abdomen, right? So that's what the left side. Hypertrophic osteoarthropathy, abnormal proliferation of skin and bone at distal extremities. Uh, this will lead to clubbing, arthralgia, joint effusions, periostosis, and this. So if you have clubbing, always think of hypertrophic osteoarthropathy, and that is always going to be linked to adenocarcinoma of the lungs. Clubbing does happen for other reasons, but they'll give you the person is coughing and is the breathing is not bilateral, the same. They'll give you symptoms of this, and then you can figure it out from the this hypertrophic osteoarthropathy that it's that. Okay, so endocrine hypercalcemia, This is PTH-RP. This is important for three things. So, squamous cell carcinoma of lung, head, and neck, right? Renal, bladder, breast, and ovarian carcinomas. This one is going to show up for renal mostly, not even three, just one. It's going to show up right here, and maybe somewhere. Yeah, I think that's it. Renal. That's where it's going to show up. So, if you have increase in PTHRP, you're gonna have other reasons why there might be these in it or not. But if there's renal, always pick that one. If they give it to you with this and high calcium, right, hypercalcemia, it's gonna be squamous cell carcinoma, right? So it's associated with squamous cell carcinoma, PTHRP. Squamous cell carcinoma of what? Lung, head and neck, renal, bladder, breast, and ovarian cancer. But if you don't remember anything, remember at least renal. The R is for renal in PTHRP. Okay. Increase in 125O2, so that's the active vitamin D. It's known as calcitriol, and it's associated with lymphomas. Then you have Cushing syndrome, increase in ACTH, and then you also have SIAD, or hyponatremia in serum, sorry, inappropriate secretion of diuretic hormone, antidiuretic hormone. So you'll have increase of ADH. So both of these happen because of small cell lung cancer. So this one is really important to remember. You'll remember it for increase in ACTH, or you'll remember it for increase in ADH, but it's both in this. And for the squamous cell carcinoma, it's vitamin D and PTHRP. Okay. Hematologic polycythemia, increase in erythropoietin. That's paraneoplastic rise in high hemocritic hematocrit levels. So pheochromocytoma, renal cell carcinoma, hepatocellular carcinoma, right? It's associated with all of that. And then hemangioblastoma and leiomyoma. Okay. Pure red cell aplasia, anemia. You should remember at least this one, because that's where EPO gets released from. But then if it doesn't happen, then sometimes the liver takes over the production. So then you have hepatocellular carcinoma. So you can think of it like that. Pure red cell aplasia, anemia with low reticulocyte, and Good syndrome is hypogammaglobulinemia. This is associated with thymoma. Then you have Trousseau or Trousseau syndrome. This is migratory superficial thrombophlebitis. You should know what this is. So let's look at that. Trousseau syndrome is an acquired blood clotting disorder that results in migratory thrombophlebitis, inflammation of the vein due to a blood clot, in association with a often undiagnosed malignancy. So I guess in step 2 is where they tell you it's cancer. But you should know that this one is associated with cancer normally. If you have this, it's going to be cancer. Non-bacterial thrombotic endocarditis, deposition of sterile platelet thrombi on heart valves. Okay, so non-bacterial thrombotic endocarditis. So that is deposition of sterile platelet thrombi on heart valves. It's associated with endocarditis carcinoma, especially pancreatic. Okay. Then you have neuromuscular anti-NMDA receptor encephalitis, psychiatric disturbance, memory deficits, seizures, dyskinesia, autonomic instability, and language dysfunction. This is ovarian teratoma. Okay, so this one and this one not too important. I haven't came across this and this. Uh, Everything else I've came across. So. Okay, so this one is pretty obvious when you see it in the question stem. Opsoclonus, myoclonus ataxia syndrome, because they'll literally describe it like the parents are going to say the kid is having his eyes are like dancing and then his feet are also dancing. So neuroblastoma or small cell lung cancer in adults though. Then you have paraneoplastic cerebellar or cerebellar degeneration antibodies against antigens in Purkinje cells, small cell lung cancer, anti-Hu, gynecology and breast cancer, anti-Yo, and Hodgkin's lymphoma, anti-Tri. Yeah, I don't think this is asked either. Paraneoplastic encephalomyelitis, that's antibodies against Hu antigens in neurons. And this one's not asked, but this one's definitely asked. Lambert-Eaton myasthenic syndrome, antibodies against presynaptic calcium channels at neuromuscular junction, associated with small cell lung cancer. And then you have myasthenia gravis, which is antibodies against postsynaptic acetylcholine receptors at neuromuscular junction, and it's associated with thymoma. I think they just added this, not sure, but they test you a lot for normal aging in cardiovascular, immune. We already did that. Renal and repro, I guess. For repro, it's just about the sex binding hormones. And respi, they definitely test you on that. Everything else, just know about it. So normal aging, time dependent progressive decline in organ function resulting in increased susceptibility to disease associated with genetic, for example telomere shortening, or epigenetic, that is for example DNA methylation, and metabolic, for example mitochondrial dysfunction alterations. Cardiovascular, decrease in arterial compliance, increased stiffness, increase in aortic diameter, decrease left ventricular cavity size, and sigmoid shaped interventricular septum due to myocardial hypertrophy. Increase in left atrial cavity size, aortic and mitral valves calcification, decrease in maximum heart rate. I zoned out like 3 times reading that, so I'll do that again. Decrease in arterial compliance, so there will be increase in stiffness. Okay, so compliance is basically how much can you push and it will take it until it pushes back, kind of thing, right? So compliance of a balloon is a lot. So think of a rubber sheet, and then if you press on it, it's gonna keep pressing. You can keep going until it recoils, right? So if it keeps going, it has increased compliance. So what happens when it doesn't keep going, right? So you have one that's really stiff compared to the other one that is really compliant. So the stiff one, no matter how much you press, it only goes in so far, right? So that's going to have a decreased compliance. So that's decreased arterial compliance because it's increase in stiffness compared to the other one. Okay, so increase in aortic diameter, that's your aorta. It's going to have a decrease in diameter because the muscles within the aorta, they start getting wasted, I guess. I don't know. It gets smaller. Because skeletal mass also decreases, right? In musculo, right there. And bone mass decreases, joint cartilage thinning. So all of that goes with that. So when that goes down, aortic diameter will get stretched out, I guess. Just remember that does that. Decrease in left ventricular cavity size. This is important. And sigmoid-shaped interventricular septum due to myocardial hypertrophy. So you need to know this to differentiate it between uh, hypertrophic cardiomyopathy and left ventricular hypertrophy, and you know, so it's left ventricular hypertrophy when the septum is also not increased in size. So if it's just the wall of the ventricle that's increased, that's due to hypertension or something like that. Right. So yeah, and decrease in left ventricular cavity. The cavity decreases in also left ventricular hypertrophy, I think. Can't recall right now, but definitely know this about the sigmoid-shaped interventricular septum. Then there is increase in left atrial cavity size, right? Also hypertrophic myocardiopathy, right? That does a similar thing as well, so that's important to note as well. But in that, I don't think there's decrease in left atrial cavity size or increase. It stays the same. So here it increases. Why does it increase? Because there's decrease in left ventricular cavity size. So before it used to, whatever blood it was giving ventricle, it was taking it, but at this point it can't take all the blood atria can give. So now atria has leftover blood, so it's going to increase in cavity size because of that. Aortic and mitral valve calcification. This is you should know this anyways, because they'll give you a question about a old person who has who had a autopsy and his aortic valve was calcified for some reason, and then they're going to ask you what does this mean, and then one of the answers will be like, because it's normal aging, right? So that would be the answer, because this happens in normal aging process. And then there will be decrease in maximum heart rate. Right, they don't need that much blood to go to things, because again, skeletal muscle mass is decreased, so decrease in blood requirement, so you can just think of it that way. And now you have gastrointestinal. Also, it's decreased because again, left ventricular cavity size is decreased as well, so it doesn't have to work that hard to push out the blood anymore. Gastrointestinal, decrease of LES tone, decrease in gastric mucosal protection, and decrease in colonic motility. So for this, there's a question about pregnancy, and it was about okay, so what causes uh, in pregnancy, what causes GERD, or what causes constipation, or what causes there was one more thing. Cholesterol stones, right? So what causes stones, constipation, and GERD? It's progesterone, because progesterone decreases LES tone, so that's lower esophageal stricture tone. It decreases colonic smooth muscle activity, so that causes your constipation, and it also decreases gallbladder motility. So if there's no motility, then the cholesterol is going to be stagnant, so it's going to create stones there. Or it can also cause infection, right? Cholecystitis. Estrogen also increases cholesterol secretion from bile. Sorry, into bile. So estrogen increases cholesterol secretion into bile. Okay. Hematopoietic, decrease in bone marrow mass, increase in bone marrow fat, less vigorous response to stressors, for example, blood loss. Uh, That's okay. Immune, know about this. There's only one thing that increases. We went over it in immuno. Where did I do that though? I don't know. Oh, right there. Okay. So immunosense is just growing old or aging or something like that, right? So everything decreases in B cell. Decreases production of naive B cells, sorry, and right. So there's only increase in memory CD8 T cells. Everything else decreases, right? So decrease in production B, no change in antibody, decrease in naive CD4 T cells, but increase in memory CD8 T cells. Then you have decrease in phagocytosis by macrophages, decrease in response to cytokines, and neutrophils, decrease in chemotaxis and phagocytosis, decrease in free radical production, decrease in antigen presenting capabilities, and in cytokine production by dendritic cells. And then you have natural killer cells, which are going to be tired out by it now. So there's decrease in cytotoxicity and decrease in cytokine production. But memories are the one that last the longest, anyways, even when everything is gone. Just getting a little philosophical over there. Okay. So predominant effect on adaptive immunity: decrease in naive B cell and T cells, preserved memory B cells and T cells. Immunosense impairs response to new antigens, for example, pathogens and vaccines. Right. Because of this, we don't give the conjugated vaccine anymore when they get older. Right. We give the conjugated one in the younger ones to cause memory response, memory T cell response as well. And also, that's why the pneumococcal vaccines contain like a lot of other strains, whereas in the for the younger ones, only the ones that there are only like 13 strains that it included in the vaccine, and is conjugated with H influenza one for the T cell, or I might have gotten that wrong. I don't know, but something like that. So you'll figure it out when it comes. Okay. Nervous: decrease in brain volume, neuronal loss, decrease in cerebral blood flow. Function is preserved despite mild cognitive decline. Okay, so there's decrease in brain volume. Okay, I think I missed this one. Musculoskeletal: decrease in skeletal muscle mass, decrease in muscle bone mass, and joint cartilage thinning. Special senses: impaired accommodation, right? That's why sometimes when people grow older, they feel like they have a better sight than before. It's because of this. Decrease in hearing, presbycusis, and decrease in smell and taste. This is why they start talking a little louder, their tone gets higher. It's because of this, and decrease in smell and taste. This is more apparent when they're talking on the phone. Skin: atrophy with flattening of dermal endoderm epidermal junction, decrease in dermal collagen, and decrease in elastin. So wrinkles. So they're gonna ask a question about like how this person uh, had a decrease in hearing. So what else is similar to the mechanism of this, right? It's just normal aging. So another example of that in the answer would be like wrinkles. So that would be the answer because that's also the mechanism of aging, right? Or it's because of that happens. So decrease in sweat glands, heat stroke, decrease in sebaceous glands, cirrhosis cutis. Intrinsic aging, chronological aging, decrease in biosynthetic capacity of dermal fibroblasts, and extrinsic aging, photoaging, degradation of dermal collagen and elastin from sun exposure. This is why you should always wear uh, sunscreen on your face. Uh, Degradation products accumulate in dermis solar elastosis. If you want to have a younger skin when you're older, if you don't need to worry about it. Reno, decrease in. There was a photo of a guy who was a package deliverer, who worked for like UPS or someone like that, and he worked along the coastline. So whenever uh, his shift was, it was during the day. So when he would go through the coastline, the sun would shine on his face on the right side. Uh, right. So then, when he retired, they took a photo of him, and they saw the difference. Like his right side seemed like it was melting, while the left side was still going strong. You know. So he was aging only on one side of the face, and the other side he wasn't aging as fast. So, yeah. Okay. Reno, decrease in. Hold on. Let me see if I can find the photo. I don't even know what to search for. Sun effects on the face of a postal worker. Yeah, this one. Hey, I found it. I'm good at Googling. I should put that on my CV. So, right there, see how it's like melting off, and then this one's not, like, this one's still taut skin, right? But this one's not taut anymore. So, yeah. This person has been a truck driver for 28 years, and this is what 28 years of sun damage does to your face. So, you should use sunscreen, just saying. Okay, so that's UVA, by the way. And then you have degradation products accumulate in dermin, so solar elastosis. Reno, decrease in GFR, decrease in nephron, decrease in. You should know all of these. So as you grow older, you have decrease in glomerular filtration rate. You also have decrease in renal blood flow, decrease in hormonal function as well. Uh, Voiding dysfunctions, which is urinary incontinence, for example. Reproductive male testicular atrophy, decrease in spermatogenesis, prostate enlargement, slower erection and ejaculation. Uh, sorry. Uh, Longer refractory period. So you should know these. They ask about this. A person will come and he's like embarrassed to talk about it, but he says that this is happening, and then you're like, it's normal for a person your age, and he's gonna be offended. It's like, what do you mean, sir? And then you're gonna have a lawsuit. Less pronounced decrease in libido as compared to females. Females, vulvovaginal atrophy, vaginal shortening, thinning, dryness, and increase in pH. Uh, then you have respi, an increase in lung compliance, decrease in elastic recoil, decrease chest wall compliance, so increase in stiffness. This is important because there are questions on lung restrictive diseases, so this comes handy if you know this. That when you grow older, you have decrease in chest wall compliance, right? Not lung compliance, because lung compliance increases, but this is the chest wall compliance. That means the chest wall is becoming stiff, but the alveoli are becoming more compliant now. Okay, so we'll do this when we do respi. Decrease in chest wall compliance, increase in stiffness, decrease in respiratory muscle strength, decrease in FEV1, FVC, and increase in residual volume. TLC is unchanged, that's total lung capacity. Uh, this is important too. This thing has no effect on TLC. So if you don't remember anything else, if you remember this, you might be able to uh, cross out like 3 of the answers out of 4 or 5, just on this. There is increase in AA gradient, and there is increase in VQ mismatch. We'll do that in recipe. Ventilatory response to hypoxia, hypercapnia is blunted. I actually went over this somewhere, I don't remember, but remember when I was talking about how, oh yeah, in TB. So in TB, it goes up in the apex because that there is wasted ventilation. It's not highly perfused, but it is highly ventilated. That's why it's called wasted ventilation. And at the base, it's highly perfused but not well ventilated, so it's wasted perfusion at the bottom. So that's related to this VQ mismatch, that whole concept. Ventilatory response to hypoxia, hypercapnia is blunted, less vigorous cough, and slower mucociliary clearance. Okay, so there. And we're done. Good job, guys.